not want our national anthems to be played like this, and that's what we're looking at. So let's look at the current status of cochlear implants. So all over the world, there are about 6.5 lakhs people who hear with the help of a cochlear implant. Almost 1.5 lakh are implanted bilaterally. In 2017, about 72,000 new implants were done worldwide. 55% were pediatrics. At least 5 times as many children still require a cochlear implant. So we realize it's a huge thing which is still needed, and we are still not looking in India at the adult market, right? So that's something which we need to look at and change as we progress in this world. And if you look at the global average, it's approximately 7 cochlear implants per million population and year. In 2008, look at the world map. So India was 0 to 1 cochlear implants per million population per year. That's how we were. In 2013, we are now up to 1 to 2 cochlear implants, but we still have a long way to go with the Western world at 30 cochlear implants per million population. When you look at the map of India, we started down south in Gujarat and Maharashtra and Tamil Nadu, and then we have spread across the country now with lots of centers which have come up. This is my state of Rajasthan. We are now doing cochlear implants regularly in 5 districts. It's the largest state of India, so it makes importance that we really shift to various nooks and corners of the state. But importantly, we need to realize it's cochlear implant is not something which will give you result in a single day. You need to be patient about it. You need to think that your results will come after certain time. So need not be very finicky that you're not getting results. It's 1 month or 2 months. The doctors need to know, the speech therapists, and we need to explain to the patients results are seen after 1 to 2 years of real good hard work. So what is a cochlear implant? Okay, so the first question which comes to your mind is it a hearing aid? Right? I love asking that to my postgraduate students. So is it really a hearing aid? Let's look at the definition of hearing aid. What is really a hearing aid? Now, hearing aid by definition includes 3 things. It should amplify the acoustic signals which exist. It should use the normal air or bone conduction pathways which are there, and it should enable the hearing impaired individual to really have a useful hearing out of it. Now, if you look at a cochlear implant, it covers the first and the third aspect, but does it really use the normal ear and bone conduction pathways? The answer is no, because it bypasses the whole of ear and has its own pathway to really help in hearing. So that's why it is not a hearing aid but a different thing altogether. Right. Now let's look at the parts of cochlear implant. Now, cochlear implant has got 2 major components, right? The external component and the internal component, right? External component has this kind of a structure. Now, this was the initial cochlear implants which were there. It had a microphone, then the wires used to carry on to something which the patients used to wear on their shirts or on the back, which had a big speech processor. And this, after coding of signals here, they were sent over to the transmitting coil. So that's what it was for the initial part of it. Now we have much smaller things, right? We are going cosmetically better, and now we have a very small behind the ear kind of an aid which has a microphone, a small speech processor, and then a transmitting coil. And the latest ones are some things like this, right? It's a very small external device which exists now. It's almost hidden in the hair, so that makes it cosmetically more acceptable, especially in countries like which we live in. Now that's the external component, right? We have a microphone, we have a speech processor, and then the transmitting coil which transmits the signal inside. If you look at the internal component, this is what it looks like. The topmost part where the circular section is existing, that has a small magnet through which it is attached to the magnet outside the screen, the transmitting coil. The coil around it is actually made of platinum, right? So that's a platinum thing, and then you see the square structure beneath that. That's a receiver stimulator package which receives the signals and then stimulates the electrode arrays which arise from it. Now this receiver stimulator package is made of titanium, so that it really is very inert. And then the electrode array which arises from this SEO stimulator package is made of platinum and iridium alloys, right? So that's the best thing for an electrode. It's covered by a silicone sheath at many places, so as to have least resistance possible. Now these electrode arrays can be of different types. Now that's something which we need to know, because we need to decide which patient needs which kind of an implant. So the one which is shown in this photograph is kind of a perimodular electrode array. It has a memory inside it. Once you remove the stellate, it coils around the modulus so that it's closest to the nerve endings, right? It's very medially placed, touching the nerve endings as much as it can. Now this can be different, and we'll discuss whether this can be a simple straight array, which would just go inside the cochlea and the scala tympani and remain along the lateral wall. Now, remaining near the medial wall, that is near the modulus, would mean it would be more specific, right? It would give us better output in this form of speech discrimination, and it will not stimulate a wider field of the spiral ganglion cells.
Dr. Manish, I want to interrupt you.
Yes, sir.
There are a lot of people watching us from various countries, which are also not English speaking.
Okay.
So some of them have requested you to be slightly slow.
Okay.
And very,
I'll do that. Yes, sir.
Slow, so that everybody can understand it throughout the world.
Yeah.
So let us be very slow in our English.
Okay,
so that
perfect.
everybody can follow.
So we'll take care of that, sir.
Yeah.
Okay, so the electrode arrays, now we have discussed about two, right? We can have a straight electrode array which remains on the lateral aspect of scala tympani, and then you have a perimodular electrode array, right, which is very near to the modulus and therefore is very specific as to the nerve endings which it stimulates. We'll have photographs which would demonstrate that better. So let's look at the other types which are available. Right, so this is the cross section of cochlea. We see the hair cells which exist, which are really in the normal person. When you look at a patient or a person who cannot hear, there are no hair cells, there are no stimulation of the eighth nerve which is happening. And when you look at an electrode which is placed near the spiral ganglion cells, it's stimulating the nerve very well. So that's the perimodular electrode array, which would stimulate the nerve endings very well. This red dot which we see, or the circle, is the laterally placed electrode array. So this is a straight array which goes in, which stays along the lateral aspect and therefore is a bit further away from the modulus, right? So these are two kinds of electrode arrays which exist. Now this is a different variety of electrode array, right? That's something. This electrode array, if you look at it, the electrodes are present only on one side, right? So when you see the numbers 1 to 16, these are half bended electrode arrays. So they would stimulate only the modulus and nothing on the lateral aspect. So this is good for the normal cochlea, but as soon as we land up with a malformed cochlea, we would have issues if the nerve endings are placed laterally. So in a normal cochlea, you can use all these electrode arrays, but for a malformed cochlea, we need to be very careful. So the moment the cochlea is malformed such that, we'll discuss that, such that the endings are laterally placed, the nerve endings, we cannot use a half bended electrode array, right? Then we use a full bend electrode array, which we saw in the previous slides. Right, so this is another type of electrode array which comes in. Now this is what we call as a high focus or a mid-scalar electrode array. Now this is not along the near the modulus, not along the lateral wall. It remains in the middle of the scala, right? So it's not exactly near the modulus, it's not exactly near the lateral wall, it's in the middle of the scala, because the theory behind this is, if you're too near the modulus, the pressure necrosis over a long time may actually affect the spiral ganglion cells. So that's the theory behind this kind of an electrode array. So that's a mid-scale. So if you look at these things, this is a perimodular electrode array. The red one is a laterally placed straight electrode array, and this light blue thing is a mid-scalar electrode. So this is in between these two. So right now we have all three options which are available, and patient to patient we can actually use that. So that's the placement of the electrode array which decides which kind of an input it would give. We also have electrode arrays of different lengths depending on the length of the cochlea and various anomalies which exist. So this can be from 28 millimeters, 24 millimeters, 20 millimeters, as we see in these photographs. So we can choose as per the patient. And this is a specific electrode array which is called as the form electrode, right? Form electrode is used when we are expecting that the surgery will have issues like a CSF gusher. So if you look at the form electrode and look at the point 3 which is labeled here, it's kind of a conical or a funnel shaped thing. So when you put it inside the cochlea, this would plug the cochleostomy site and help in preventing any CSF egress later on. So these are the electrodes which can be used for patients when we are expecting a CSF gusher to happen, right? Now two more important things. We have electrodes which are called as split arrays. So there are two arrays, one of them goes in the basal term, the other in the middle term. When do we need to use them? We use them when we have an ossified cochlea or a labyrinthitis ossificans. So we can put part of the electrode array in the basal term if that's patent, If the rest of the part is really ossified and the middle turn is okay, then you put the second part in the middle turn, right? So that takes care of almost all the frequencies possible. And if you look at the compressed array, and if you think that your patient has majorly ossification present in the middle turn and the apical turn, and the basal turn is free for you, then or the patient has a malformed cochlea with only the basal turn being useful, then you can use compressed arrays which has the same number of electrodes over a narrower length of the or a smaller length of the electrode array. So these are two options which are available for malformed or ossified cochleas. Now let's see a video on how a cochlear implant functions, right? So a cochlear implant, as we saw,
helps people with severe to profound sensorineural hearing loss or nerve deafness.
It has
A cochlear implant has two parts, an internal part called a cochlear implant and an external
the
part
external
called a
component
speech
has a
processor.
microphone which we just
The
saw.
speech processor has a small
and a
microphone
transmitting coil.
which picks up
Microphone receives the
sounds.
signals. It would amplify the signals and send it to the speech processor, where it would code the signals so that they go to the transmitting coil. The transmitting coil will then send these signals to electromagnetic induction to the internal component, and the first thing which receives the receiver stimulator package. This then sends in electrical signals to the electrodes which are present inside the cochlea, and the spiral ganglion cells and the eighth nerve are stimulated. So this is how a cochlear implant functions. It's a completely joint device. We need to know that once we have any implant placed in our body, we have to look at the compatibility to MRIs, right? Because all of us almost certainly will require an MRI in our lifetime. So let's look at the compatibility. Now, most of these implants, cochlear implants which are available, are compatible with 1.5 Tesla. So that's not an issue if you're doing a routine MRI. The moment you need a higher level of Tesla for your MRI for your patients, there are few which can undergo a 3 Tesla MRI if you remove the magnet, and there are few which you can get a 3 Tesla done without removing the magnet. Now the problem is there are two issues. One, the compatibility, and the other is when you have an artifact because of magnet. Now let's look at these scans. The first patient scan is a normal cochlea, right? Normal patient. There's no implant inside, so you see it very normally. When you have a magnet and it's a 1.5 Tesla, this is a huge artifact which you get. And when you have a magnet removed with an implant in place, is a very small artifact. So that would mean that an option of a removable magnet is helpful if you require it for a higher Tesla MRI. So especially for the area of the brain or the cerebellopontine angle, if you are going for operations of a patient who had undergone a surgery for CP angle tumors like in NF2. So then you need a removable magnet to really follow up with your patients if you require an MRI later on. Okay, so we come to second part of this talk, is that the candidacy, right? Who requires an implant and whom of them can undergo a cochlear implant. Now selecting the right candidate, as JANAKIRAM and sir must have been really thinking, it's the candidacy selection, whether it's a skull based surgery or whether it's cochlear implants or any other surgery for that matter. Selecting the right candidate is the most important thing. Now this can be a very simple thing to look at it sometimes, but it can be confusing, and we may think that something is really the right candidate and may not turn out to be the right candidate. Let's leave aside the political aspect of it. Let's come to the criteria for cochlear implants. The foremost important thing is which age do you implant in. Now we can really think of a child who is born till the age we die, and if we look at the worldwide perspective, the youngest patient to be operated upon is 3 months of age, and the oldest one is 108 years, right? So that's the scale which they have been operated upon. Obviously, this would matter if we are dealing with a prelingual or a postlingual patient. Now, prelinguals are those who lose their hearing before developing speech, right? For example, when we discuss about children who are born with a hearing loss, so the minimum age for them as per US FDA criteria, look at those criteria. Initially they were approved only for adults. In 1990 they went to 2 years, and the present status is 1 year. Now as I said, 3 months child has also been operated. There are many centers who are operating at 6, 8 and 10 months. So the future probably something which withholds for us is we will have an in utero kind of an implantation if it really happens, and we would have these kids being treated by some or the other means, not just implants, but yes, some of the other means, when we can really cure them before they are even born. The maximum age is something which we really need to be more careful about, especially with government programs coming in, especially with implants and lot of lawsuits happening, the medical legal issues which come in. We need to discuss is the maximum age we can operate upon, right? So the term which we use here is neural plasticity. Brain is a plastic structure. It can really undergo a lot of changes, but after a certain age, these changes are very slow and sometimes do not happen. So the best age when you can actually make the changes in brain is below 3 years of age, and as you go beyond 5 and 6, this neural plasticity decreases. Now we'll have a short, can you just go back to the slide? We'll have a short video on that, right? Which shows the neural plasticity. It's basically when the brain is actually showing the way, no, it doesn't have any audio, so yeah, it's just showing the way the neurons really are changing when you're giving any input inside. It's a functional MRI, and the brain has got neurons which keep on making newer and newer connection, and that's how the neural plasticity comes in, right? So these connections which are made decrease as the age progresses, and therefore the results of cochlear implant beyond a certain age are not good. Now, not good is a very relative term, right? So for me, if I want to see the patient really hearing well, speaking well, singing, I want to operate them before 2 years of age or 3 years of age. If we are really spending government money, we want the best results for that. Now, but if I have a relative of mine who is, let's assume, a girl of 17, 18 years, and the parents are ready to spend money with the expectation that that hearing which she gets will be limited to just environmental awareness, 16 years, 10 years, 12 years, hearing a loud horn while walking on the street, then that implant can do. But if you tell your patient at 16 years that she would really hear and speak and sing, that is where problems start happening. So the maximum age becomes relative with what is expected out of an implant. What are you doing it for? But the best age would remain before 3 to 5 years, right? So that's where you can get almost a normal child when you do a cochlear implant. With only postlingual, the duration of auditory deprivation rather than the age factor becomes more important. The more the auditory deprivation, the more are the chances that that auditory cortex is being covered by other cortex, right? Other motor areas of the brain take care of, or the sensory areas of the brain cover that part, and therefore the results go down the more the auditory deprivation, right? So operate them as early as possible, but even if you operate them 10 years after auditory deprivation, they would still be better than operating a 10-year-old prelingual patient. So that's the age criteria. We come to the audiology. Now, pediatric patients, or the children, when we are planning to evaluate them for audiology, we need to get them checked out for behavioral audiometry. We need to check the otoacoustic emissions, auditory brainstem responses, tympanometries, and if required, an ASSR and the aided audiometry to see for the hearing. Now, you do not get all the tests done, but at least an OE and an ABR and tympanometry are essential for evaluation. We want for the best of the patients that these should show us severe to profound sensory neural hearing loss, which is not retrocochlear, right? We want to see that the OE should indicate that the hair cells are not functioning, that is the OE is refer, and therefore we implant in these patients who have a refer OE with a severe to profound sensory neural hearing loss. The important thing is all these kids need a hearing aid trial, right? So what's that trial period? When do we go ahead with an implant? Now that's decided on a case-to-case basis. If the child is less than 2 years, a hearing aid trial for 3 months is what is recommended, so that we know which kids would improve how much. If the child is, however, more than 2 years, we are losing on precious time, and a hearing trial of 6 weeks is good enough. However, here comes the exception of labyrinthitis ossificans. Do not give a hearing aid trial for labyrinthitis ossificans, because that would only lead to more ossification and thereby decreasing the results and making the surgery more problematic. Sometimes may even land up a contraindication for surgery. So other than a patient with ossified cochlea or a fibrosing cochlea, we can actually try for a hearing aid depending on the age. When do you refer for cochlear implants? When there is no significant improvement with the hearing aid, or there is a progressive hearing loss, or the aided responses are falling outside the banana curve, so the response is not good enough. Now let's come to what happens in audiology in adults, right? Now tests will be almost similar, but here comes the role of speech audiometry. Now speech audiometry is important because we are looking at speech discrimination in these patients. So we cannot have just an audiometry and not discrimination which comes here. So speech discrimination score of less than 40 are what we are looking at if we are looking for real good results in these patients. Now hearing aid trial, most of these patients who come to us, adults, they are already have tried a hearing aid, and when they are not happy with it, they really try to go for a cochlear implant. So that's again very individualistic, but most of the times they have already used a hearing aid. And if the audiogram or the ear audiogram shows that these responses are falling outside the speech spectrum, we need to plan for a cochlear implant. And as I said, if the SDS or the speech discrimination score is less than 40, we plan for a cochlear implant again. Now the indications have expanded over time. It initially was only profound loss, it went to severe and profound, and now we are even doing with those who have a hearing which is normal in the lower frequencies and have a high frequency hearing loss. So these are the ways the indications have expanded for a cochlear implant. And the evaluation should include always an evaluation of the central nervous system. If there is a developmental delay, the results would be compromised. If there is severe mental handicap or a IQ level which is low, the results would again be compromised. And a patient with an autism or an ADHD, attention deficit hyperactive disorder, they need to be managed together along with management of hearing loss. You cannot leave the one aspect and go on to the other. The results will be compromised in that way, right? So that's where the role of a pediatric neurologist comes in.
So, Dr. Monesh, I think we'll take some questions.
Yes, sir.
We'll make it more interactive.
Yeah.
So, we request all the people who are seeing to ask a lot of questions so that we'll make it very interactive and not just like a lecture. Now, there's a person from Jammu and Kashmir who is asking this question, Ishfaq Ahmad. What will be the results when we operate hyperacusis postlingual patient? Will he be comfortable? Will they be comfortable with the implant?
So the criteria for operating on an adult would be when the patient is not able to hear, right? You have a severe to profound sensorineural hearing loss in both the ears that we are looking at implanting. Now, if you really mean to say by hyperacusis, that the problem comes in that when you're giving an input, it really is a painful input to that particular patient because of the input which is given is very high levels. That can happen in adults because of involvement of the nerve in that way. Then it's just that you need to manage them very well, right? You need to do a mapping. The speech therapist and the audiologist do that so that the input which goes to the brain is not something which is troublesome. It should not be causing pain. But otherwise, if it's simple hyperacusis, you do not do a cochlear implant. You do it only when you have a severe to profound sensorineural hearing loss. Is there any other question, sir?
Yeah, that's a very nice answer. Please carry on, Dr. Monesh.
Okay, so if you look at the candidacy criteria, the second part is the family has to be motivated. The patient and the family both need motivation. They will have to work hard to really get results. That's what we need to explain them beforehand. And the expectations out of an implant should be really such that they don't really feel that the surgery which was done was not useful, right? Because as I said, if you're operating on a 12-year or a 10-year-old kid, the results are going to be very less as compared to operating on a 1 or 2-year-old child, and that's what needs to be explained. So beyond 5 years, the results go down, and that's what needs to be explained very well to these patients.
So, a small comment here by Dr. Gunashekhar from Kerala. Can you please reduce the speed of your talking, as foreign doctors may not follow the speed with which you are talking?
Okay, so we'll slow it further. So, if you look at the criterias, right? So these are the whole criterias, which the medical criterias, the etiology, if it's labyrinthine ossificans, you need to consider that. The audiogram needs to be considered, severe to profound sensorineural hearing loss, aided audiometries, speech perception for adults, and the outcomes and expectation which needs to be explained well to these patients. Just to summarize, like as Dr. Gunashekhar mentioned, so that it's easier for everyone to understand, the selection criteria for a cochlear implant would be age more than 1 year for a prelingual patient, That's a US FDA criteria, but not beyond 4 to 5 years if you're really looking for very good results. Severe to profound bilateral sensory hearing loss. That's again important. It should be bilateral for the best results. More than 70 decibel loss is what we're looking at, with minimal or no benefit with the hearing aid, so that we know that this child will not benefit with the hearing aid, and only then we go ahead with the cochlear implant. There should not be any major mental handicaps, right? We just talked about autism, ADHDs, which if present need to be tackled at the same time. It's sometimes questioned if a patient with cerebral palsy should really undergo cochlear implant or not. So we need to realize that the results of cochlear implant will be lesser, but if it gives some input to the brain, it would actually help the child to have developmental issue improvements in other faculties, right? So it would help his overall development more. So that's something which is again important. And as we talked about, family support and realistic expectations are an important aspect. But the candidates obviously should not have a contraindication general anesthesia. The middle ear infection should not be active, it should be controlled well, and cholesteatoma should be taken care of before implanting on these patients. If there is any severe malformation or a severely ossified cochlea, it becomes a contraindication. With expertise and experience, we can actually implant the minor malformations and lesser ossifications, right? So that's again which can be done. If the patient has had a tympanic membrane perforation, the ideal thing would be to operate, and then second stage we do a cochlear implant after 3 months. People still do it at a single stage also, but waiting for 3 months makes a lot of sense, so that you are sure that you have taken care of the primary pathology here. And we do not want any deafness in the acoustic nerve involvement, right? Or central auditory pathways need to be evaluated well. That's where radiology and audiology comes in. Most important thing, so we see in Indian scenario, is to catch these kids early, to do a newborn hearing screening. A universal newborn hearing screening is what we are looking at, so that the best results come up. And screening with follow-up, something which we all know, Dr. Molly talks about CI registry, right? So that's what it's important. Do hearing screening, follow up these patients so that we catch them early and implant them at the right age. It's kind of an emergency, otologic, neurologic emergency, so that these patients can be taken care of in the initial part of their lives, right? So that's something which is important. So what have we achieved in our state? This name of deaf, dumb and blind still remains, though it's contrary, but they have put in this board which mentions otherwise. So they still name this which achieves, which remains, but the other board which you see, that blue colored board which has come up on the school for these hearing and speech disabled kids, which still needs to be really changed. Okay, so we just have a small video to show what we are looking at, and we hope this is what our kids will be, and we will be able to reach that. So that smile tells us all what the difference which we can make in the lives of these kids and their families, right? Okay, so thank you for that. This is the first talk, right? Basics about candidacies. It's also about the team which should exist. It should not be just a single person working it. The results cannot come. This is a wide field, requires a lot of people, right, from surgeons, psychologists, pediatricians, audiologists, speech therapists, and all of them really come together to get the best results for our patients.
So I think we have come to the end of the first lecture, and I think we are being watched by around 1,200 people across the globe, which is a good number for a period where the soccer match is going on. That's very good. So I have a few questions to you personally. So a patient who has been operated before and loses hearing, bilateral cholesteatoma, who loses hearing. So, and suppose some of the semicircular canals and all are also totally removed because of petrous bone cholesteatoma on both the ears, then what is your take on such patients?
So if it's something in which the cochlea is not operable upon, then only we go for something else. If the cochlea is remaining, the nerves are intact, then these patients require a subtotal pectorosectomy, which probably has been done if you have really done it, but with the cul-de-sac closure, and then we put in an implant through that. However, if the nerves are something which have been affected, or the cochlea is non-operable or has been meddled during the surgery, then these patients would require an auditory brainstem implant. So then we go to the next level in that case.
So I think Dr. Monish has covered the whole spectrum of candidacy, and now we'll go on to the second lecture of his, and over to Dr. Monish, please.
Yeah, thank you. Okay, so now we come to the more important aspect, right? That's something which we are supposed to do. That's radiology, because reading a scan of temporal bone, whether it's a CT scan or an MRI, is a difficult job. Most of the audiologists or radiologists do not know what we require out of them, and we cannot rely only on their reports. So radiology is an important aspect, and we are supposed to know it ourselves rather than really relying on it. Yep. Okay, so let's see. Now, in present day, radiology is really advanced. They can do a lot of things for us and change the way we look at these things. They can really predict by radiology as to what the future course of this patient will be, how the surgery needs to be done, and therefore it is an important aspect. Now, if you look at the world, even in Europe, they have done the first robotic cochlear implant, right? So they have used robots with navigation to go ahead and do a cochlear implant, and that's what has been possible primarily because of radiology. So that's how advanced radiology is. It's just that we should know what we get out of these radiologies, right?
So let us take a couple of questions, Dr.
Yep.
Manish. For one from Nikhil Singh, is OME a contraindication for cochlear implant?
Okay, so that's an important thing. If I were to know pre-operatively that this patient is having OME, that's by tympanometry and looking at the tympanic membrane, I would try correcting it if it's non-retracted tympanic membrane, right? We're talking of simple OME here. We try correcting it by decongestants, by taking care of adenoids if required. But if on table I even come to know that there is some kind of a glue present, we can still go ahead and do implants because it's not infected. The only issue is during surgery we may find some edema present, so that may actually cover a few landmarks, like round window may be covered and so by the edema which is there, so you will not see the things that clearly. But simple glue here, minimal edema, you are not really worried about. You can go ahead, even if I find a lot of edema inside, I am able to see the landmarks properly. The implant doesn't remain a contraindication. You can, on that same time, you can suck out all the glue and do a cochlear implant. So it is not a contraindication.
I agree with you, Dr. Monish, because our last implant was actually patient with OME, and we operated on that patient, and the patient is doing well.
They do.
We have one more question. What is your take on auditory neuropathy?
Okay, so I thought I would discuss later, but becomes important here.
No, discuss later. We'll come with the flow.
Let it be, because when we talked about candidacies, that's something which can be touched even now. So auditory neuropathy, these patients need to be evaluated very well. This is a wide spectrum of disease, right? You can have these patients who can do well just with rehabilitation and therapies. They may do well with a hearing aid and they may do well with a cochlear implant, and at the end of it they may not do well with any of these things. So here comes the role of an audiologist and speech therapist. The first thing you need to do is get these patients under a good speech therapist who can really do some good work on them. Give them a hearing aid so that you see the results which are coming out of it, and then if nothing works out, the MRI shows the nerve to be pretty well functioning anatomically, then we go ahead and do an implant. So there are patients who are being operated by cochlear implants even if they have ANSD or auditory neuropathy. They do well, but you always have to counsel them otherwise too, right? So they are not contraindications, but they may have very variable results, and that's what we need to understand when it comes to that.
Yeah, thank you very much, and you please carry on, Dr. Monish.
Okay, so what type of imaging are we looking at, right? So X-ray mastoid is obviously a no. We are looking at HRCT temporal bone and an MRI temporal bone in brain. That's what we need to advise. Now, when you advise an MRI temporal bone to a radiologist, specifically please do ask for a Fiesta or CIS image. That is just a hyperweighted kind of a T2 image, which on axial section would show you the 8th nerve contrasting against a very intense CSF background, right? So the 8th nerve or the cochlear nerve specifically would be seen much better on a Fiesta or CIS image. You need that image on every patient who undergoes a cochlear implant, and also a sagittal oblique view of the internal acoustic canals. When we see those 4 dots, we'll see these in the further future slides also. So you need to see those 4 nerves in the internal acoustic canal when you take a cross section through the sagittal oblique view. So let's look at this. We want the CT scan like this with a good cochlea, good middle basal apical turns seen. The image on the right is the Fiesta or the CIS image, which is an intense background, which we, like many times you get a cystonogram, right? Or you get a hyperweighted T2 image for looking at CSF through the into the panel sinus. It's a hyperweighted T2 weighted image again here, which you see the CSF as a very intense signal, and you see the nerve contrasting through that, right? So that's a straight cochlear nerve which is seen, and if you get a sagittal oblique view, which is seen on the left side lower cut, you see those 4 dots for the facial, superior vestibular, inferior vestibular, and the cochlear nerve. So you need to look at the cochlear nerve which is lying in the anterior-inferior quadrant and be sure that that is present. We'll discuss this more as we go ahead. So we look at the CT scans. This is what a normal axial CT scan looks like. Now we look around the world around us, we see it's all colored. We enjoy that aspect of it. Especially Indians are very colorful, right? That's what is good about India. And if it's actually something interesting that our CT scans still continue to be black and white, right? If I were to have a CT scan which is shown in the lower cut here, and maybe just click on that, yeah, then I could see the similar structure in the coronal and sagittal. It would something which would help me a lot to study these scans in an easier manner, especially in the initial part. So is this really possible? Yes, it is. Now we have softwares which do that, and let's look at the software, right? We can really play with this. So if you look at it, the first thing which is mentioned, can you just be a bit slow on that? Yeah, so the first thing which is being mentioned is all off, right? Can you just go there and click on the arrow there? Let's go to the all on right here. Okay, and we see everything colored. So the green dots which are there are the semicircular canals, right? That's where it shows. That's a superior semicircular canal. That's the posterior limb and the anterior limb. Can you just go one level down? Go to slide number 26 on that. Yeah, so we keep on seeing this. Yeah, let's go down further. Right, so that's the internal acoustic canal, and this would, if you click your cursor there, let's see your cursor on this, yeah, okay, anywhere which you think you need to be labeled it as, that's a superior semicircular canal. Click on that and you will really see this. Click on that. Can you click on that? Yeah, so we see this coronal sagittal view of the same thing as you see on any console on the CT scan or the MRI doing the consoles which are there, but this being colored actually helps us. So now let's go back to the normal mode. Can you go to the all off? Yeah, all off mode. Okay. And we go down, so we see all the superior semicircular canals. What we see arising from that is the posterior semicircular. Now we see the internal acoustic canal coming in. Can you be a bit slow on that? Yeah. Can you go to the previous cut? We see the labyrinthine segment of the facial nerve arising. That's the labyrinthine segment just going up to the first genu. You can go to the next cut, and then we see the cochlear structure. So all those structures which are present anterior to the internal acoustic canal are the cochlear structures. Anything which is posterior are the vestibular structures. So what we see posterior to the internal acoustic canal right now is the vestibule. We also see the lateral semicircular canal. Can you just point to that? Yeah, so that's the vestibule. We see the lateral semicircular canal. If you see a small line running, yeah, inferiorly, just come below. Yeah, so that's your vestibular equivalent. So this software tells you that's your vestibular equivalent. Now this is the normal width of a vestibule aqueduct. In fact, tomorrow the patient we are going to operate upon has a large vestibule aqueduct. So it would be interesting to see the difference in the scans here. So that's a normal vestibule aqueduct. Now if you see the cochlear structure present anteriorly, the first cochlear structure which comes in is not the basal turn but the middle turn of the cochlea. Right, that's something which you need to know. It's sometimes may seem that the basal turn should appear first, but it's the first turn to appear is the middle turn. That's the superior most part of the cochlea which comes in. Let's go to the next section. When we go to the next section, we see more of cochlea. The basal turn now starts coming in. We see the tympanic segment of the facial nerve, and we also see the ice cream cone appearance coming into view now. Right, that's a malleus and incus with the tympanic segment of the facial nerve and the basal turn of cochlea. We go to the next and we see more well-defined cochlea. That's why we're looking at. We see the sinus tympani region just inferiorly. Can you go to that area? Yeah, so that's the sinus tympani. We go, just lateral to that lies the facial nerve. So you know your. Can you see the lateral part of it? Yeah, that's the facial nerve. So you know your relation of the facial nerve to the cochlea. Right, so this is where you need to plan out your surgery, and we'll see how the round window is related to that. We go to the next cut and we see the round window appearing. So that black dot just near the basal part, right? That's okay. Can you just go a bit more medially? Okay, no, yeah. So just beneath the basal turn, that's your round window, right? So that's a round window. You have the sinus tympani, and then you have the facial nerve. So you know how much the facial nerve would really be covering your round window. So we have a special cut which we would discuss as we go along to really see which patients would have a good visualization of the round window, and when we can plan a round window insertion easily without really hampering the angulation which we are going in. Okay, so we go to the next cut. That's the whole of cochlea. That's the basal turn middle apical with the round window which is seen beautifully with the facial nerve which tells us that it's looking good. That's so the segment which appears now is the cochlear aqueduct. It's just appearing near that cursor which you see. That's the cochlear aqueduct which is appearing. That would connect the basal turn of the cochlea, the scala tympani region, to the middle cranial fossa. So when the patient has meningitis, the infection spreads from here to the basal turn scala tympani. That's the first area therefore to get fibrosed in most of the cases, right? We need to look at this diameter also, and so we are going superior now. Let's go inferior, yeah. And that's the internal carotid artery which comes in. So that's good enough. We need to see our scans. We'll discuss the aspects which are important for cochlear implant as we go through. Can we go to the presentation now? Yeah, so now the important relations to the cochlear implant. What things we need to look at when you're really looking specifically for cochlear implant? Okay, so if you were to enumerate them, middle ear cleft anatomy, the inner ear amphitrus apex, and the central auditory pathways. These are three sub topics in the radiology for cochlear implant. Middle ear cleft, we look at the mastoid, the pneumatization and its size, we look at the facial nerve, we look at the various vascular structures, we look at the status of the middle ear, and then we look at the round window. Right, let's start looking at these things. This patient, for example, we can see that this patient has a sclerosed mastoid. Now, this is a sclerosed mastoid, but what I would be more interested in is the things which are seen on the left. Now, this patient also has a very forward-lying sinus, sigmoid sinus on the left side, right? So my planning, if both the ears are pretty much similar, is that left side would be surgically more difficult for me. The mastoid would be very narrow, the facial access opening may be very narrow, so we would rather be happier to operate on the right rather than on the left. The jugular bulb is commonly associated with a high jugular bulb when you have a forward lying sinus. So be on a lookout for the sigmoid sinus in all these patients. Vis-a-vis, this is a patient who has a hyper-pneumatized temporal bone, and therefore the facial nerve may be just hidden behind one simple thin bone slice, right? You may actually be doing a posterior tympanotomy, you remove that bone and the facial nerve gets exposed. So be wary when you have either of the conditions, a sclerosed mastoid or a hyper-pneumatized mastoid, because in both these things we may be having initial issues with our surgeries. Facial nerve, we are more interested in the vertical aspect, right? So rarely this may be duplicated, as we see in the inferior cuts, right? If it is a duplicated facial nerve, you need to be very careful when you're doing a posterior tympanotomy. Even when you're doing a Varia technique, you need to be very careful, because this duplicated facial nerve may come in our way. It may actually sometimes be over the promontory and therefore hamper a cochlear implant per se. And a very rare thing can be an internal carotid which is aberrant and covering the whole of promontory, that are making cochlear implant almost impossible. Right? Important structure, round window. We just saw that in the when we discussed the CT temporal bone. Now this cut is what we is called as a minimal intensity projection reconstruction of the sagittal view, right? The importance of this cut is we see the whole of the basal turn and we see parts of the semicircular canals. Now if we were really to plan our surgery, so then this is the area we would go in with a round window approach, right? This is the round window which is seen. Now if we were to go through a round window approach, we will have to drill the niche and then go in, and then the electrode would really go in like this. Vis-a-vis, the green arrow shows the straight way to a separate cochleostomy. Now why different approaches? Round window approach is considered to be better by the latest views in terms of hearing preservation. There are views which exist in a different manner, but lately the things which are coming are more in favor of a round window insertion. You need to do minimal drilling on the cochlea. Therefore, it's considered that if you have the patient has a residual hearing or you want to preserve the ear structures, probably this would be a much better thing. However, we have had studies, cadaveric studies, which show that the trauma may be similar. With one of the studies done by Dr. Kapil Sikka in AIIMS, which showed that the cadaveric result with respect to the trauma to the inner ear was similar in both the techniques, but in live patients many times it's considered round window might be helpful for preserving the residual hearing in a much better way. However, if this angulation is very bad, we would actually go ahead and do implantation through a separate cochleostomy, which is the more conventional way, that is an antero-inferior cochleostomy. So we do not want the last picture to be the real thing. We do not want such a huge kinking of the electrode array, because that would almost certainly lead to an incomplete insertion.
So I think we have one question, we'll take that.
If there is anything like posterior rotation of the cochlea.
Yeah, so I'm very happy, Dikshit, that you have really asked it. Now, can I really reserve that question for a bit later? We are really going to discuss that maybe 15-20 minutes from now, and I would be able to explain you much better. Okay, so bony pathologies can be like this. You need to look at, this is the Paget's disease causing a hearing loss, and you cannot do a CA here. You can have otosclerosis, which classically shows a double cochlear type of a pattern and therefore becomes problematic when you are really operating them. And really you can have things like Langerhans cell histiocytosis, which may again require radiology to be read in a much better way, pre-disease, post-disease, and so that you are pretty sure that the disease is over now and you can go ahead with an implantation, right? So the bony pathologies need to be studied. So that's the middle ear aspect. Most important, that being the round window. You need to look at that very well. Let's look at the inner ear, right? So cochlea, malformations and ossification need to be studied. We need to look at the vestibular aqueduct, the large vestibular aqueduct syndrome. We need to look at the internal acoustic meatus, whether it is narrow, malformed or enlarged. We talk about cochlear duct length, and then we talk about orientation of cochlea. So that's about the posteriorly rotated cochlea which Dr. Dikshit just asked. The orientation of cochlea, we'll discuss that, and then we look at the cochleovestibular nerves. Okay, so this is the histopathological photograph of a cochlea, right? CA is what we call as cochlear aperture. That's where the nerve endings from the cochlea come out and they form the cochlear nerve and then travel in the internal acoustic canal. The modulus, we all know, that's the axis around the cochlea is rotating, that again has all the nerve endings. And then we have the basal, the middle and the apical turn, and we have various septations which are marked by these arrowheads. If we were to make a line diagram, this is how a cochlea would look like. The cochlear aperture, modulus, basal, middle, apical turns and the septations, right? This is what is the most important thing to understand. That's the normal cochlea. We see it on an MRI, we see the division between scalar tympani and vestibuli. and we can see the various turns. The lower picture which is there is the CT scan, which shows the basal, middle and apical turns with the round window. So that's how a normal cochlea would appear on radiology. Let's look at the ossified cochlea. Now, the moment we have a post-meningitis hearing loss, that's something we are always looking, or a post-trauma hearing loss. If you have a white speckled appearance inside the cochlea, right, you see those white dots, this would indicate some kind of an ossification happening, and this would actually make your surgery difficult. The results may be a bit compromised. So that's where you need to look at the ossification. If you get a reconstruction done, you look at these reconstructed cochlea, you see the basal turn is very narrow. So you will have to actually drill out the cochlea in this area to reach the lumen. That's where you need to be careful when you're reading your radiology as to what and where the lumen will be possible to put an implant in. So that's where radiology comes in. Now, it's just not a CT scan. An MRI has a very important role. Look at the first picture on the left. It shows fluid in the cochlea. When you look at the second picture, there is no fluid, right? So no fluid would mean two things. It could be ossified, as we saw in the CT scans, or it could be fibrosed. Now, fibrosis would not be seen on a CT scan. So the initial phases post meningitis is what we see is only fibrosis, and your CT scan may show it's all normal, but your MRI will tell you if it's a fibrosing cochlea, and that's what would make your surgery challenging. You will pre-operatively be ready for it. You will explain the patient that this is what we are really seeing. So less fluid or a less intense signal or an absent signal on an MRI is a very important sign in post-meningitis or a post-trauma hearing loss patients. So always look at the cochlea, the fluid in the cochlea very carefully when you're looking at the MRI. Now, Indian perspective is a bit different. We all know economics plays a big role. So we cannot waste time, especially in post-meningitis patients, that they may actually develop a lot of ossification in the cochlea, leading to an almost contraindication for cochlear implants. So we need to take care of it before the patients are able to arrange funds for the same. So we have a paper from Dr. Kirtane which came in. So sir has actually done, and we did it one at our place also. What he advises is that you put in a stent in the cochlea by the time the patient arranges fund for the cochlear implant, so that even if you have to wait for 6 months, this cochlear lumen will be preserved for putting in an implant at a later date. If we were not to stent the cochlea, this cochlea would get ossified and therefore not allow us to put an implant at a later date. So this is actually a very useful information for a country like ours, where this cochlear stenting would help us do a cochlear implant even at a bit of a later date by the time the funds for the cochlear implants are arranged. We come to inner ear malformations. Now this is something we need to understand. We know that all that glitters is not gold, and similarly all that is malformed in the cochlea is not Montanese dysplasia. We need to be clear as to what is Montanese dysplasia and what is not Montanese dysplasia, because the results, the surgery, the complications would actually depend on the type of malformation. So the most important classification which exists today in the world is Naroglu classification, which came out in two of his papers in 2002 and 2010. And these terms include complete labyrinthine aplasia, or what we commonly call as Michel deformity. Then we have cochlear aplasia. Then we have common cavities. Then we have cochlear hypoplasias 1, 2 and 3. Then we have incomplete partitions, again 1, 2 and 3. Large vestibular aqueducts, right? So this is the 2010, we'll talk about this. This is the 2010 classification of his. In 2013, he himself modified this by adding two terms, rudimentary otocyst and cochlear aperture anomalies. And in the latest paper of his in 2016, he added the term cochlear hypoplasia 4, right? So this is the whole classification. I mean, this is something we all need to know in today's era. If we are talking about what malformations of cochlea, then we should know what an IP2 means and what does a cochlear hypoplasia 3 means. We'll discuss this out in future slides. Now this gentleman, Sanaroglu, actually went ahead and did a lot of hard work. He's from Turkey. He spent 1 year of his in Harvard just studying those temporal bones of cochlear malformations, and telling the people of the world that it's not that all of them which have been labeled as Montanese are actually Montanese. So it's his contribution, and the slides which I show, a lot of them are going to be from his papers as to what is really happening inside the cochlea. So let's go about this classification one by one.
So just a comment here, Dr. Manish, we have been watched by around 3,941 people.
Several people from all over the world are saying that it's a fantastic program. All thanks to Alamjit as well as Dr. Manish for making it here. And thanks, you can carry on.
Most common thing which we see is a large vestibular aqueduct. We saw in our CT scans that normally vestibular aqueduct is very narrow. You may actually not see it on a CT scan many a times. However, if it is enlarged, as we see in the inferior cuts, and if it is more than 1.5 millimeter at its middle, it's considered to be a large vestibular aqueduct. Now we see that. Can you just point to that area? Yeah. So just beneath in the CT scan, that's a large vestibular aqueduct going on. So that's an endolymphatic duct which is enlarged going to the sac, and that's a large vestibular aqueduct. Now, what's the importance of a large vestibular aqueduct? Large vestibular aqueduct patients are known to have a progressive hearing loss. Many a times, this hearing loss happens because even a minor trauma to the head, even a pat on the head, would transmit this impulse to the inner ear, right? So this simple pat on the head would give a lot of pressure to the inner ear, which would cause progressive hearing loss. That's one of the theories behind it. This would mean that if you see this patient, always evaluate these patients for thyroid problems, because you have Pendred syndrome, which is goiter associated with a large vestibular aqueduct. So that's something which you should always evaluate. And third important thing is, these patients, when you do a cochlear implant and you open up the cochlea by cochleostomy, you will always see some pulsations happening in the cochlea, because these are the transmitted pulsations of the brain which you would be able to see. Now, usually this would not be a very severe egress of the CSF, just small ooze which is present. However, if it is associated with other anomalies which you need to look out for, if you have a large vestibular aqueduct, you may have a CSF gusher happening. So these patients usually do well. Isolated large vestibular aqueduct, they do very well because they are progressive hearing loss patients. The auditory cortex is already well developed. Just that you need to know that you will have those pulsations happening around. Okay, let's look at the other malformations in this classification which have been mentioned. Right, so we had this patient. Now this patient, she had, and this is a 16-year-old girl probably, she had been operated for bilateral chronic otitis media. Bilateral tympanomastoidectomies were done at some center. She came to us with a bilateral profound SNHL. Now the right ear was still discharging, as is evident on the first cut. There's still some debris in the right side mastoid cavity. Left side was very well healed. So we had actually planned that we will go ahead and do a left side cochlear implantation after doing a subtotal petrosectomy and cul-de-sac closure. We got the radiology done, and what we saw was that the inner ear was absent on the left. So this, as we see in the last cut on the right side, there is no inner ear. The cut in the middle shows the right side with the infected cavity with a normal basal turn, middle turn and apical turn, maybe just a slight ossification, but the left side did not have inner ear. So we were now having a situation of an infected cavity which required a formal surgery of subtotal petrosectomy with a cul-de-sac closure, and then we did an implant on the right side. So that's where radiology comes in. Clinically, we thought we would be better off operating on the left side, but there is the radiology which tells us that that was something which was not even possible. So this patient underwent right side cochlear implantation. That's complete labyrinthine aplasia or Michel's deformity. Now, so neurology has actually classified complete labyrinthine aplasia into these three categories. Let's start from the most severe, the most inferior part. So the most simple part, right? Complete labyrinthine aplasia, but the otic capsule is present. That's the most inferior section which you see. So that's the facial nerve which is traveling through that last cut. So that's complete labyrinthine aplasia with an otic capsule. It becomes more severe when complete labyrinthine aplasia without otic capsule. You have some form of petrous apex present. Petrous bone is there, but the otic capsule is now completely absent, And then the most severe form is you do not have the petrous bone at all. So it's a complete aplasia with complete aplasia of the labyrinth as well as petrous bone. So the brain directly touches the middle ear. There is no petrous apex or the petrous bone happening. So these are the sub-classification of complete labyrinthine aplasia, and complete labyrinthine aplasia and an absolute contraindication, as is obvious, for cochlear implant. These patients will require an auditory brainstem implant. Less severe form, but again a complete contraindication, an absolute contraindication for cochlear implant is a rudimentary otocyst. It's just a small bud of inner ear with the almost stenotic internal acoustic meatus. So it's commonly associated with no nerve endings, is again an absolute contraindication for cochlear implants, and cochlear aplasia. So these three, complete labyrinthine aplasia, rudimentary otocyst, and cochlear aplasia, are absolute contraindication. Now how do you identify cochlear aplasia is something important. As we discussed, any structure which is anterior to the internal acoustic canal is the cochlear structure. So you see the cut on the right side, you see the cochlea which is present there, right? So that's as Dr. Abhilasha is pointing, that's the cochlea. If you see on the left side, you have some inner ear, right? But that's all posterior to the internal acoustic meatus, and therefore that would mean that that is only the vestibular system present. There is no cochlea on the left side, and that's what we call as cochlear aplasia. We need to understand this because that is important to be distinguished from a common cavity deformity. A common cavity deformity will be on all the sides, the inner ear will be on all the sides of internal acoustic meatus, while a cochlear aplasia would be only inner ear structure present posterior to the internal acoustic meatus. So that's a cochlear aplasia, classical cochlear aplasia, a absolute contraindication for cochlear implant. So we have seen complete labyrinthine aplasia, we saw rudimentary otocyst, we are seeing cochlear aplasia. These three, as I mentioned, are absolute contraindications for a cochlear implant. Common cavity, this is a patient we see, that's an internal acoustic meatus. The inner ear is present all around it. So this has some cochlear structures which are present. So this patient can undergo cochlear implantation. The results will not go, but still better than a brainstem implant. So this is a relative contraindication in the sense that as we grow in experience, we can go ahead and do a cochlear implant in these patients. So importantly, if the inner ear structures are only posterior to the internal acoustic meatus, we do not do a cochlear implant. But if it's present anterior as well, then that means that we have some cochlear structures which are present in this cavity, and therefore that's a common cavity. Now let's look at the term cochlear hypoplasia. Okay, cochlear hypoplasia by definition would mean two things. You have to have smaller external diameter.
Okay, sir. Congratulations, sir. Congratulations, sir. Yeah. Yeah, sure, sir. I'll do it. Okay, sir. I'll do that, sir. Yeah, sure, sir. I'll tell him, sir. Okay, sir.
Type 2, again smaller as per the definition. The septum may be absent or smaller here. The modulus is present now, right? So that's the difference between cochlear hypoplasia 1 and 2. The modulus is present, but it is defective in the upper half, right? So that becomes cochlear hypoplasia 2. Cochlear hypoplasia 3, you have smaller cochlea, but there are still 1.5 turns now. The septations are present, the modulus is complete now. Cochlear hypoplasia 2 modulus was incomplete. It's a complete modulus now, but it is smaller in dimensions. The turns are less, therefore the dimensions of the modulus are smaller. And the cochlear hypoplasia 4 is when the septations modulus are present as was there in cochlear hypoplasia 3. Importantly, the basal turn is absolutely normal in cochlear hypoplasia 4. The middle and apical are hypoplastic. So if you, the 3 and 4 are differentiated only by the presence of a normal basal turn, which would make it cochlear hypoplasia 4, and therefore the results would be much better. If you were to look at the photographs, then this is what the cochlear hypoplasia 1, 2, 3 and 4 would be. 1, as I mentioned, no septations, no modulus. 2, when you have small septa, modulus is smaller and we don't see any modulus in the upper part of cochlea. Type 3, when you have a complete modulus dividing even the upper part of cochlea, but it is much smaller than a normal cochlea, the modulus is much smaller. Type 4, the basal turn becomes normal. The middle and apical are fused together or are hypoplastic, right? So 1, 2, 3, 4 cochlear hypoplasias, these are the definitions which exist, right? So this is something which we need to know. The second category which is confusing would be incomplete partition. Now these are the histopathological photographs of the same, right? Cochlear hypoplasia 1, we see there is no septations, no modulus, just a globular thing which is mentioned as C, and that arrow represents a very minimal division between the internal acoustic canal and the cochlear structure. So that's something which can be broken when you're putting an electrode in. Cochlear hypoplasia 2, the middle structure C, which shows a very small modulus, very small septations, and it's actually a defective modulus in the upper half. And then the type 3, when you have a complete modulus but it is smaller in size, right? So that's how we differentiate 1, 2 and 3. We talk about incomplete partition. Now the distinguishing factor between incomplete partitions or IPs and CH, right? Incomplete partition cochlear hypoplasia is, as by definition we saw, cochlear hypoplasia has to be smaller in dimension. Incomplete partitions would have a normal dimension, right? They would be as normal in dimension as a normal cochlea. The inner structures would be deficient. So cochlear hypoplasia would look small on a CT scan. Incomplete partition would look like a normal cochlear dimension on a CT scan. How do we differentiate between incomplete partitions now? So incomplete partitions are again 1, 2 and 3. We would revise these in the next 2-3 slides. Incomplete partition 1, when the septations are absent, modulus is absent, right? So that's kind of a cochlear hypoplasia 1 if you look at it. But when you have a normal size cochlea with the septations which are absent, the modulus which is absent, it becomes incomplete partition 1. And this is what it would look like, right? Incomplete partition 2 is when the septations are present in the middle turn but absent in the apical and middle turn, right? And modulus is complete. So IP2 is what we call as a Mondini's deformity, right? If you ask a Mondini's deformity, it would include 3 things: an IP2 deformity, enlarged vestibular aqueduct, and a dysplastic vestibule, right? So this is what you need to know. Not every other thing is Mondini's. It's only IP2 with large vestibular aqueduct with a dysplastic vestibule that we will call it a Mondini's deformity, right? So IP2, that's the most important thing, because IP2 is commonly seen rather than other malformations. So IP2, your basal turn is normal, the middle and apical are actually absent or fused together, right? So you do not have any differentiation between middle and apical, and the modulus is completely present, right? So that's how in the basal turn, right? So that's how you get very good results, because the basal turn is the prime area for our stimulation of the cochlea. IP3, you would have septations present but modulus absent. So let's see the CT scans of the same. Incomplete partition 1, this looks like a normal dimension cochlea, but there are no septations, there are no modulus, so it's a big cavity. These patients are known to have high chances of CSF gusher. Almost 30% of these patients would have a CSF gusher when you open the cochlea. So this is an IP1 deformity on a CT scan. IP2, the basal turn looks normal, right? But the middle and apical are fused. You do not see any differentiation. That arrow which is present shows that there is no differentiation in the middle and apical turn, and it is associated with the large vestibular aqueduct, the white arrow, and a dysplastic or an enlarged vestibule. So that's a Mondini's deformity. IP2, large vestibular aqueduct, and a dysplastic vestibule. And the last thing is IP3. When you look at that IP3, it's kind of like the whole of the internal acoustic canal is having protrusions, right? So IP3, it's a big communication between the cochlea and the internal acoustic canal. There is a 90% to 100% chance that this patient will have a CSF gusher intraoperatively. Also, when you're putting in an electrode array, it would go directly into the internal acoustic canal, so we need to be very careful. In IP2, we can use any kind of electrode array, right? Because the basal turn is at our disposal. So we can use any electrode array in IP2 anomalies. In IP1 and 3, we can only use full band electrodes and those which are straight, right? We cannot use perimodular electrodes. So that's where radiology is important. IP2, any electrodes. IP1 and 3, only straight electrode array which are not long. Even the shorter electrode arrays are what you are looking at. So this is the differentiation of IP1, 2 and 3. Just to really summarize, these are the line diagrams of the same. The A and B are the normal cochlea. C is the normal vestibule, D is a dysplastic vestibule, E is a common cavity, right? It's present on all the sides of internal acoustic meatus. F, G and H are IP 1, 2 and 3, and the lower 3 are actually cochlear hypoplasias 1, 2 and 3, right? So this is what they would look like on a CT scan. We especially need to know what an IP2 looks like, right? Do not forget that. Even if we can really get in our minds from today's lecture that this is what an IP2 is, then that is important because that's where majority of our malformations will lie, right? So IP1, 2 and 3, and then cochlear hypoplasias 1, 2 and 3 which are shown. The 4 is not shown because that's the latest edition which has been really made to this classification. Now it's very confusing, right? But this is a summary of all. So if you can just note down this table somewhere, this is always useful, right? So cochlear hypoplasias 1, 2, 3 and 4, just to revise this, cochlear hypoplasias 1, can we have the animations coming in, right? So cochlear hypoplasia 1 is when the septations and modulus are completely absent. 2, when the septations are smaller in size but not present everywhere. Modulus is defective in the upper half, it's present very small, defective in the upper half. Type 3, when the septations are intact, the modulus is intact, but again modulus becomes very small, it's only 1.5 turns. Cochlear hypoplasia 4, the basal turn is absolutely normal, the middle and apical are fused, right? So that's where the cochlear hypoplasias lie, and all these cochlear hypoplasias would be smaller in diameter, the smaller in dimensions than normal or incomplete partitions. Incomplete partitions, you have septations absent, IP1, modulus absent. So, and a big communication between the cochlea and internal acoustic canal leading to CSF gushers. IP2, most commonly seen anomaly, normal basal turn, middle and apical fused together, right? No septations between that, and that's where a Mondini's would come in. And IP3, very bad thing to deal with, almost 100% chance of a CSF gusher happening, and a misplaced electrode array inside the internal acoustic canal is very much possible, right? So these are the classification that they exist. Now importantly, when I tell them, I remember them for the initial few days. Most of these students I talk to, they forget it the next day because they are very confusing. It's like spotting the difference when you look at these electrodes, like look at these malformations. If I were to really ask you to really spot the difference in the first photograph, it's just this scar length and the fact that the lady is not wearing any earring, and in the inferior part you don't see the ear. And if you look at this various structures in the malformed cochlea, it actually becomes very difficult to remember this classification, and that's where the problems start appearing. So though a lot of hard work has gone behind this classification, but as of today it's very confusing for most of us, and that's where the uniformity goes in. So the question is, why do we need a classification? It's obviously, it makes things easier, it brings in uniformity, it helps in treatment planning and prognosis. Now let's look at the complications, obviously, if we can really predict them. We had initially Jacklers classification, then we had Phelps classification, and latest is Sonoroglu classification. We just discussed that. Now Sonoroglu classification, yeah, this is the whole classification which exists as of the latest 2016. If we look at it, do we really need a new classification? Because this classification which exists, though very exhaustive, is confusing. It really doesn't help us in many ways, because the purpose of a classification, as we talked, it's to make the things appear easier. Now, can I really distinguish between IP2 and CH3? If I were to ask you that, most of you and even me and most of the surgeons would find it difficult to do it at the first glance. IP1 and CH2, it's again difficult. And if I were to ask myself, if I would remember this classification after 1 week, it's going to be very difficult, right? So, does it bring in uniformity? It does to a certain extent, but we still have gray zones, and especially the fact that most of the surgeons find it difficult and the speech therapists do not even understand this classification is what makes it difficult. Can we do our treatment planning as per this classification? Now, if we look at it, most of the classifications would really fall from the severe deformities to a more complicated deformity. So which malformation has a high chance of CS of Gusher? And if I were to give you options of CH1 to
Because it's a call from Alembic, sir is not picking up, so they called me. Before it gets finished, just do an ishara and tell him that he has to announce it. Okay? Okay, ma'am.
complete partition 1 and then incomplete partition 3, right? So that doesn't really make much of sense to make it easier for us. I would be rather happier to have a classification which tells me that maybe CH4 and IP3 are the ones associated with high rates, high chances of CS of Gusher, rather than IP1, CH2 and then IP3 having a higher chance of CS of Gusher. If you look at the prognosis again, it's not that IP1 has a better prognosis and then IP2 has a worse and IP3 has the worst. IP2 has a better prognosis than 1 and 3. It's again something which makes it very difficult and in fact very odd to say that a middle part of this classification would give us better results than 1 and 3, right? So if we were to look at prognosis in cochlear hypoplasias, 3, 2 and incomplete partition 2 really cannot even tell in present day as to which has a better prognosis, and that's what makes this classification a bit difficult from the clinical aspect of it. For me as a surgeon, this classification becomes very good if I want to read the theoretical and pathogenesis part of it, but clinically somehow or the other it creates a confusion in my mind. So we have devised, and this has gone into publishing now hopefully, a classification to make things easier for all of us to understand, right? So cochlear vestibular malformation, that's CVM, we have given them categories A, B, C and D, B divided into B1 and B2 and C divided into C1 and C2. Now let's look at the CVM type A. If it is normal cochlear morphology, that's cochlea is absolutely normal appearing on your scans, modulus is normal, and labina cribrosa is normal. So these are only the 3 things which you need to look in every scan of yours: cochlear morphology, modulus, and lamina cribrosa. Lamina cribrosa is nothing but the cochlear aperture, right, from which the nerve endings are coming into the internal acoustic meatus. If all these things are normal, the only abnormality is being in the semicircular canals or the large vestibular aqueduct. This is CVM type A, which would give you normal results, right? This is the best patient to operate on. B is when the cochlear morphology now becomes abnormal. The lamina cribrosa remains normal, but the modulus becomes defective. Now this could be defective in the sense that B1, the modulus is complete but smaller in dimension, and B2, it is partially defective, right? So B2, you will have a defective modulus in the upper half. So B1 and B2, only the modulus becomes problematic, the lamina cribrosa remains normal. C, you have problems both at the level of modulus and the cochlear aperture or lamina cribrosa. So C would mean that it could be a deficient lamina cribrosa or a normal lamina cribrosa, but the modulus has to be completely absent. So abnormal cochlear morphology, absent modulus, right? That's where C type of CVM comes in. If it is a normal lamina cribrosa, that means the connection between the cochlea and the internal acoustic canal is not big, the chances of CSF gusher are not going to be there. However, if it is a deficient lamina cribrosa, that's where we land up with higher chance of CSF gusher and therefore misplaced electrode arrays as well. And type D, absolute contraindication. You have absent modulus, absent lamina cribrosa, so you have nothing. It's kind of a cochlear aplasia. The cochlear morphology is nothing there. So cochlear morphology, no cochlear structures being there, makes it an absolute contraindications. Just to clarify, A, everything normal, B, deficient or smaller modulus, C, absent modulus, can be with normal lamina cribrosa or deficient lamina cribrosa, that is C2, and D when everything is absent, either aplasia, complete aplasia, cochlear aplasia, whatever. So this is where the SMS classification, which we have given it in the name of our Institute of Cochlear Vestibular Malformations, comes in. Type A, as we talked, would include any anomaly isolated remaining to vestibular aqueducts or the or the semicircular canals. B1 would include CH, cochlear hypoplasias, 3 and 4 will be included. B2 will have incomplete partition 2. So that's where Mondini's dysplasia comes in if it is associated with vestibular aqueduct and dysplastic vestibule. C1 can have an IP1, common cavity or cochlear hypoplasias type 1 and 2. Common cavity and CH1 and 2 can be part of C1 and C2. Right, if you're really to correlate it with the previous classification, depending on the lamina cribrosa, if it is deficient becomes C2, so common cavity can have a deficient lamina cribrosa and then it becomes C2, and D would be a complete labyrinthine aplasia, rudimentary otosystem, cochlear aplasia. All three terms lie with D. So importantly, what I want to emphasize is, if you're looking at a malformed cochlea, look at these three things: cochlear morphology, modulus and lamina cribrosa. All these three things, and you look at these three one by one and you would know which patient would do which fare the which way. Let's look at examples. If you look at the prognosis, A, B1, B2, C1, C2, D, it worsens as we go from A to D. There is nothing like B1 will do better than B2, will do worse than B2. That's where the importance comes in, makes it easier. If you look at complications, C2 will have higher chances of CSF gusher when you have a deficient lamina cribrosa, and therefore the misplaced electrodes can go into the internal acoustic canal. You look at the treatment planning. With A, it is a routine surgery. B1, B2, again routine surgery, but do not plan for long electrode arrays or for a complete cochlear coverage because the modulus is smaller here. C1, you definitely need smaller electrode arrays. You cannot use perimodular arrays. You have to use full banded straight electrode arrays and may need to modify surgeries, that is the CSF gushers may sometimes be present. C2, you will always have CSF gushers. You have very high chances of misplaced electrodes, and the CSF gusher may require electrodes like form electrodes, which we discussed, a bigger cochleostomy, and requiring things like glue, and even prepare ourselves for subtotal petrosectomy. And D would mean a contraindication for a cochlear implant. So we have to look in the categories of A, B, C and D and decide the treatment plan as per this classification, which makes it simpler. So look at the cochlear morphology, look at the modulus, and then look at the lamina cribrosa to decide what you need to do with that particular patient. So as I mentioned again, three things to look on radiology for cochlear malformations: morphology of cochlea, modulus, whether it's present or absent or defective, and lamina cribrosa. Remember what is Mondini's deformity, that's B2 as per this classification, or incomplete partition 2. So that's with large vestibular aqueduct and a dysplastic vestibule. So that's the whole of malformation. It's a very confusing thing, but when you see the scans, always remember to see the normal structures and correlate it with the malformed cochleas. Remember what a Mondini's deformity really is: the normal basal turn, fused middle and apical, with an enlarged vestibular aqueduct and a dysplastic vestibule. That's the most basic thing which we all should know. Right.
Just a comment, Dr. Monish Grover. First of all, real big congratulations for you. You have brought out a new classification. I think it's going to be published shortly, and it's being viewed by around 7,570 people around the world. In fact, right from South Africa, Nepal, so many other.
So, really nice classification. And I think you're going to operate tomorrow as well. I think it's going to be a type A, according to you.
A type A malformation, right? This patient has only a large vestibule aqueduct. So what we expect is that this patient might have some pulsations coming in tomorrow from the brain, which may be actually seen as transmitted pulsations. Other than that, this patient should do well. Yeah, so that's what we're looking at.
Tomorrow morning, just to announce to the 7,570 people who are watching this, that tomorrow morning at 10 o'clock.
Indian Standard Time.
Sir's voice goes off.
Start our relay of a cochlear implant surgery being done live at Royal Pearl Hospital, and that will be done by the legend Dr. Monish Grover. Thank you, Dr. Monish. You can carry on, please.
Okay, so now we come to the questions which Dikshit asked about rotation. But before that, let's answer a question. Are all normal cochleas similar, right? We need to look at that perspective to it. So I have a small videos to show you, right? Let's look at this girl, right? So she's trying to walk in shoes which are obviously, that's okay, we don't need any audio, which are shoes which are obviously oversized, right? She's trying to walk, she's very uncomfortable, falling again and again, and then finally finding them too painful and therefore leaving those shoes and walking barefoot. She's more happy doing that. Let's look at this cute boy, right? He's probably wearing his age appropriate footwear, walking happily, not just walking happily but helping others wear shoes, right? So we look at this and we realize that everybody has a different feet. I cannot wear Dr. Janakiraman's shoes. I cannot even step into his shoes any day. Wearing his shoes is obviously also going to be very difficult. So when we look at all this perspective to it, we should also ask ourselves, is the cochlear duct length same in everyone? And now importantly, till date we are actually using cochlear implants made on the basis of Western studies which measured the cochlea of a Western person from the more developed countries which have bigger skull, bigger body structure than what we have, and therefore probably different cochlea, and we have been putting our implants based on those. Now we actually joined hands with New York Eye and Ear Infirmary, and the formula which was worked out by Dr. Alexads and Dr. Jolly is what we used. Now we get this minimal intensity projection cut, right? That's the sagittal reconstruction which we talked about, and then you are supposed to measure the distance from the round window, as you see that line, from the round window passing through the modulus to the lateralmost aspect of the cochlea. That is something which is called as A, which in this particular patient was 7.7, and if you put this into this equation, the cochlear duct length would come out to be 4.16A minus 3.98. Now this would give you length of every particular patient you are operating upon. If you are dealing with a smaller cochlea or a shorter cochlea, or you are dealing with a longer cochlea, that's something we tell you. Let's look at the significance to it. It's not only related to the fact that we are talking about complete cochlear coverage here. Even if you are looking for only basal turn coverage, this calculation becomes important, and probably we'll see more and more things coming on this aspect. And we have actually done it in our setup, and we found that the cochlear duct length in our set of patients was a range of 28 to 34.3 millimeters with an average of 29.8 millimeters cochlear duct length. If you look at the literature which is there, this will tell us that it's variable in all the studies, right? All studies agree that it's a very variable length of cochlea which exists, and which is actually seen in our study as well. However, we also find that in our skulls, the Indian cochlea is probably much smaller, maybe because of the structure which we have. It's probably a shorter cochlea which we have. So it's variable, that's agreed worldwide, and it's smaller in our population. That's what we are speculating. What does that mean? Now the first implants which were made on the basis of the thought that cochlear duct length is approximately 35 millimeters. So if we go in 25 millimeters as per the Greenwood's equation which exists for here, we would stimulate the lowermost frequency of 500 hertz. That's the lowermost speech frequency we want to be stimulated. If you go in deeper, we are going to stimulate much lower frequencies and generate noise. We may also damage the inner ear structures for which the present day electrodes are not made for. So the first structure, the first cochlea is the cochlear duct length assuming 35 millimeters. If we put in a 25 millimeter electrode array, we would stimulate the best frequencies possible. If however the cochlea is longer, we would stimulate much less. Importantly, if it is a shorter cochlea as we see here, we would go in much more deeper, right? We would be not knowing and actually going in deeper, stimulating much lower frequencies, maybe even causing inner ear trauma. That's something we do not know whether we are really doing it or not. We are just putting in electrodes in all our patients right now. And if you're doing a separate cochleostomy, you're already 2 or 3 millimeters more in. So that would make you much more deeper. So a shorter cochlea which we have and doing a separate cochleostomy, using the standard electrode, we may actually be damaging a lot of things out here, right? So this thing has been extrapolated, and now in few centers across the world, the electrodes are individualized for that particular patient, and so that's something which probably we'll see more and more happening as to the length of the electrode array being decided by the length of the cochlea of that particular patient. The second newer concept which is coming in is whether when you look at the CT scan and you look at this cochlea, simply this cochlea, whether this cochlea is similar to this cochlea or they are different, right? That's where the question of orientation of cochlea comes in. And when Dr. Dikshit asks what is there something called a posterior rotated cochlea, then that's what we look at. So to really look at that, we just draw a mid-sagittal line on the CT scan of the axial section, right? We draw a line along the long axis of the basal turn of cochlea, and then measure the angle between these two. So this is the axial section. We draw a line along the mid-sagittal plane. We draw another line along the long turn of the long axis of the basal turn. We measure this angle and we call this as angle alpha, right? So we checked it in our set of patients. It's very variable. In fact, both the sides have different angles on both the sides. And in our 84 patients, in which we checked 154 years, because we had to exclude few on the basis of cochlear vestibular anomaly, we found an average alpha was 57 degrees with a very variable range. In 53 of our patients, we checked it with the intraoperative ease, and we realized that whenever alpha was less than 50, that would be difficult in surgery. Now that would be difficult because that would mean the lesser the angle, more posteriorly rotated or most posteriorly oriented will be the cochlea, more recessed will be the round window, and more angulated therefore will be the electrode insertion. That's what is important. So Dr. Dikshit, this is what a posterior oriented cochlea is. You have an acute angle cochlea, and that would be more posteriorly rotated, and therefore that would lead to more difficult insertions. However, the world literature is a bit different, and it's not that always it's going to be easy insertion with alpha more than 50. There is only one study in the world which actually has done it differently from us, and that's a Sigmund Lloyd from UK which has done, and they found that more the angle, so they found at 66, 63, they had more difficulties in insertion. So we went ahead, we did the same calculations again. That's the alpha angle which we calculated, and then if we draw an imaginary line along the posterior tympanotomy axis, right, that's the facial nerve, the annulus, and we draw a line, and then we calculate the angle between this axis of the surgery which we are going to do with the long axis of cochlea, measure this angle as angle beta. If this angle is more, that would mean difficult electrode insertion, because you would actually need to tackle this angulation much more. So this is again very variable with our set of patients, and this range was variable. We have this calculation, these calculations, and they have been accepted for publication in JLO. But whenever beta angle is more than 20, can we go to the previous slide? It is going to be very difficult. So an alpha less than 50 and beta more than 20, your radiologist can do it easily for you. You would have difficulty in round window insertions. So you may actually have to plan these patients for a separate cochleostomy. Right. So this is something which probably should become as a routine part of an imaging checklist. These are internal acoustic meatus. They need to be normal. You cannot have a narrow internal acoustic meatus because that would mean that you're looking at a stenotic eighth nerve, right? So that is, you look at the serratal oblique, and that's what we need to discuss. The C dot, that's the fourth dot in the anterior inferior quadrant, is the cochlear nerve. If the dimension of this cochlear nerve are lesser than the dimension of the facial nerve, we are dealing with a hypoplastic cochlear nerve. So that's where these four dots are important. If it is absent, it becomes aplastic. If it is smaller in diameter than the facial, it becomes a hypoplastic cochlear nerve. Now these dysplasias have been classified 1, 2, 3 and 4, but for us the most important thing is if we are really seeing cochlear nerve to be absent or hypoplastic, that's where we need to really tackle them well. You need to look at the central auditory pathways, obviously. So when you look at smaller acoustic neuromas which may be coexisting, or in CMV infected patients you may have large cystic areas involving the auditory lobe, making the results obviously questionable out here. So that's the whole of radiology, right? That's detailed radiology, what we all need to know about it.
So I think that's the end of the second topic. It was really exhaustive, Dr. Monish, and I'm really impressed with your classification, which is going to be published, SMS classification. In fact, I find a lot of similarities between you and me because I also published a classification.
I know that.
We're now coming out with another classification for the pituitary. And actually, we have to suit our own cases, which are present in India and also in the developing countries. I think this is something which all the youngsters should take home, a carry home message, and how innovative this young legend is in the field of cochlear implants. In fact, we're being viewed by around 9,000 people around the world, and it's actually a big credit which all goes to Alembic, which has started this program. Special thanks to Alembic. Very nice reception by the audience, despite the fact that it's World Cup football being played all over. And also to start with the third topic, over to Dr. Monish, please.
Thank you, sir, once again. Now we're talking about the surgeries out here. So because we are going to see one surgery tomorrow, so maybe we can actually go with about this thing in a bit of a hurried manner if we want about it. However, we need to realize that the success depends on a teamwork. Yeah. So let's look at this. Soccer is in way. Let's see how these players are really working. All of them working. The opposite team not even touching the ball, but every player in the other team having its own role, and the person who actually scores had never touched the ball before that. And that's the team we need even for the cochlear implants. Even if a single person is missing out of this puzzle, the picture is not going to be good. That's where we need to look at. The other thing which success depends on is depending on the kind of atmosphere we are working in. Let's look at this small video, right? Everything, small thing becomes important out here.
Hurry up, yeah. I'm sorry, I'll be late. Let's see. तू अंदर क्या कर रहा था? सर मैं टेस्टिंग कर रहा था। कपड़े बदलने से पहले बल्ब बदलो।
Right, so before doing the surgery, we need to get our things in place. It's not just surgery. We need a setup like Dr. JANAKIRAM sir has. Before he does the skull-based cases, he has the best of equipment and infrastructure. When you're doing a planning an implant, get a good microscope with a good illumination inside. That's something very important. Get good drills. Always have an angled handpiece with you. Get good burrs, right? The success of your surgery will depend on these things. And obviously, the knowledge of anatomy is the most important thing. You cannot do a surgery without that. So let's look at a few things which are important. Round window, is it really round? Various studies done, it's anything but round. Now if you look at the three-dimensional shape of round window, it's actually saddle shaped. It's kind of like a Pringle chip. It's, if you look in the terms of physics, It's called as a hyperbolic paraboloid, right? That's what the shape of a round window is. So that would mean that the anterior inferior part is vertical and the posterior superior part is horizontal. And when the patient is lying down, we actually do not see the posterior superior part, we see only the anterior inferior vertical part of round window. So the importance of this is it's very closely associated to the osseous spiral lamella and the posterior aspect of it. So if our electrode array is actually directed even slightly posteriorly, we would actually penetrate or deflect off the osseous spiral lamella and land up inside the vestibule as is seen in the CT scan here. So instead of going in the cochlea, we may land up inside the vestibule, and when you're doing NRTs or any kind of neural response checking in the surgery, you would actually see some waves coming in because the vestibule would actually send waves inside the cochlea, but the result would be very compromised. So posterior part of round window is where you need to be away from when you're putting an implant in. Now this whole area of the middle ear near the round window is the round window chamber, right? We know the structures, the fustus, we have been talking about it, Proctor's area and everything. But more importantly is what lies beneath the round window. Now this projection inside the round window is the crest or fenestra, and the moment we drill it, we see the structures inside. So this area is what we call as the hook area, because it's kind of a hook in which you need to go in and then take a turn. We drill the crest or fenestra and then we see the inner structure. So the scalar tympani, as you see in this line diagram, is directed in a very angulated manner from the round window. So you have to direct your electrode array in the direction of the scalar tympani and not bang it straight inside the round window membrane. That is where you land up in traumatizing either the basilar membrane area or the electrode itself. We also need to realize that the cochlear aqueduct and more importantly the accessory canal to the cochlear aqueduct are located right near the basal turn, right in the basal turn near the round window area. So if you're drilling on the crest or fenestra to open up that area, do not go very inferiorly and damage the accessory canal, especially because it carries a vein, right? And if that vein gets damaged, you have issues in the cochlear vasculature and you do not want to see that. So that's something which you need to remember, that's a part of it. But whenever we do a temporal bone dissection, always open up these areas. So see the round window, see the scalar tympani, just above that you will see the basilar membrane, just above that you have the scala vestibuli and then the modulus. So you should know where to go in. If your scala tympani is ossified, you know where to go for scala vestibuli. So these are the structures you should always dissect off in a temporal bone dissection. We'll just go about this surgery or we can actually, do you think we can skip the surgery today, sir? Because we are going to show it tomorrow. If we have,
we are going to show it tomorrow, so you can join us tomorrow at 10 a.m. for the technique of surgery. We will just discuss the other aspects of surgery.
Yeah, so if you are dealing with a malformed cochlea, we talked in detail about it. Always look out for other malformations, especially the facial nerve. We choose the electrode specially as per that, specifically for that particular cochlea. If the basal turn is normal, we can use any kind of electrode array, but if that is abnormal, then we need to decide in a full band versus a half band, and we do not really use a perimodular array anyhow. Now if the patient is a CSF gusher, what to do? Let's look at a video of a CSF gusher first, right? So CSF gusher, it's seen in IP3, IP1 anomalies. The moment the cochlea was cut here, the round window was cut here, you see CSF leaking in, right? That's filling your cavity. You have to keep your suction near that cochleostomy site, and then you push in your electrode array, sucking the fluid along the way while you are inserting the electrode arrays, right? Do not suck directly on the cochlea, but keep it just near the cochleostomy site and keep on inserting your electrodes. If it's just a minimal ooze, it would stop in some time, but if it's a gusher as was seen in this case, it would require sucking along with insertion and then sealing the site of cochleostomy very tightly, right? Importantly, you need to make your cochleostomies bigger, right? If you make a narrow cochleostomy, which you do for your routine cases, it's very difficult to plug the peri-electrode sites. For example, if you created a cochleostomy like this and it's an electrode which goes in, you have some space around the electrode, you can plug in those sites with soft tissues. If it's a narrow cochleostomy, your electrode goes in, the space between the electrode and the bone doesn't allow you to really put in things inside. So you cannot seal that side well. Still, you should always be prepared with the fibrin glue, always be ready, and if possible in IP3 and IP1, keep a foam electrode with the funnel shaped sealing so that it's proper. Be ready, consent for a lumbar drain, and if required a subtotal petrosectomy, the worst come worst scenario. Let's look at a few complications, right? Now, importantly, can we play this video? We need to realize something which is being shown here. Is it
I
playing?
have a question, Dr. Monish.
Yes, sir.
You can take that question.
Yeah.
So, what is the role of subtotal petrosectomy in case of a perilimb gusher?
Okay, so if it's a very severe CSF gusher and it's not really getting stopped, or even if it gets stopped with difficulty when you really seal it well, there is a chance that it may leak again. So if that's kind of a severe gusher which is present, then you would actually like that this site be cut off from the external surroundings, external world, from all the places, right? You do not want the infection to creep in. In fact, these are the patients then who land up with meningitis on a later date. So you want to really cut off this area from the external world. So you remove all the epithelium, do a subtotal petrosectomy, close off the eustachian tube, do a cul-de-sac closure for the external auditory canal, and then do a cochleostomy impotence. So even if there is any leak, these patients do not land up with any meningitis. So that's where the subtotal petrosectomy comes in. Okay, so if we also need to realize that all of us as surgeons, especially as cochlear implant surgeons, no issues, not paying. Let's go to the next slide. We have a great power in ourselves to really give a good gift. Now, these are all the kids which improve with the cochlear implant, right? You give them and their families a very new life, a very happy life. But this gift can be easily converted into a curse, right? And this is where the problem comes in. The moment this converts into a curse in form of any complication, it's very difficult to deal with it. One of the most problematic thing can be facial palsy. The patient already had one cranial nerve problem and you actually give him another. Is not something which is acceptable. But if this happens, what to do? If you have an immediate post-op more than HB grade 4 palsy, you need to really go back and look at your surgical video if you have recorded of that. And if there is any doubt of the nerve getting transected or nerve getting compressed by the electrode, you need to plan for a surgery. If it's less than grade 4, you can plan for a conservative treatment, right? It could be simply putting them on steroids and require, if you think it could be a viral reactivation, put them on antivirals and just wait, it would resolve. You don't need to do anything. If it's secondary, obviously you manage it conservatively. You don't do anything. Now there have been studies which say that if you have actually meddled with the chorda tympani a lot during your surgery, you may have a higher chance of a viral reactivation. So be wary of this fact if you're dealing with such kind of a thing happening. Revision says surgery may be required for infections, for rejections, for device failures, for electrode migrations, misplaced electrodes, damaged electrode arrays, and displaced magnets. Right, let's look at this video again, right? There are some things which can be revised.
It's an ad.
Thank God some things in life are rewritable. Ultra smart range of CDRs and DVDRs from Eurovision.
Okay, nothing.
Be revised. There are some things which can't be revised, and with cochlear implants, revision is very difficult. There are lots of issues which come in. Let's suppose issue about decision making and consent. You have to maintain the vascularity of flap when you are really revising this case. You will actually see a lot of fibrosis, lot of knee osteogenesis happening, and you actually need to preserve the integrity of implant many a times when you are revising it. So this is one video, right? You are seeing a lot of fibrosis, and when trying to dissect it off, this is how the electrode array can be inadvertently damaged, right? You see the way this scissor actually got into that electrode array. So you need to be wary of this, and I could easily have actually cut the electrode array because it's a very delicate structure. Now what can go wrong with the electrodes? It can be placed, people have placed it everywhere you can imagine near the aortic capsule, right? It's gone inside the carotid, it's gone in the second picture, you see the eustachian tube, it's hitting the facial nerve, it's in the vestibular system, and even inside the internal acoustic canal. So you name it and people have put it there, and it's something which is still happening. So this is one of those cases. She was a 60-year-old female who she had a progressive hearing loss, uncontrolled diabetes, poorly controlled diabetes and hypertension. She underwent cochlear implant in November 2015 at some place, and the operating note mentioned that the ossification was present. An incomplete electrode insertion was therefore done, and the neural response was obtained only from electrode 6 to 11. Right, this is what was mentioned. However, the radiology, and this is the photograph of that neural response telemetry which was done. The radiology, when we done the post-op X-ray, showed this kind of an electrode array. Obviously, this doesn't look to be very good. It's kinking which is present. The patient obviously did not show improvement, and on otoscopy there was a posterior marginal perforation. Right, and we got a scan done. Now, when we see the electrode array, they are actually entering inside the carotid canal here, right? It's between the carotid artery and the bone of the carotid canal. That's where the electrode array is lying. We got the axial section done, and that's where the electrode is going into, just entering the basal turn in this section, then leaving the basal turn and entering the carotid. Now what's probably happened is that the surgeon is drilled through the basal turn, remaining more interior, and then entering the carotid, thinking that's the lumen of the cochlea. The lumen of the carotid canal was actually confused with the cochlear lumen, and the electrode was inserted in that. Right, so the issues involved were, now the 60-year-old female, what's the risk to the carotid? If we are really putting an electrode out of the carotid canal, could it be damaged? Especially in elderlies, when you have muscle resorptions and internal carotid arteries, they become more frail, or they sometimes become rigid due to atherosclerotic patches. Will it be a risk when you're pulling out the electrode array? If also, do we operate in the same ear or the other? Do we put the electrode in the scala tympana or the vestibular, because the basal turn has already been meddled with in the previous surgery? And also, whether you use the same implant or new one. The patient's family was not from a family who could afford a lot, so we decided to use, now here the consent is very important, right? We decided to use the same implant. We took a consent that we may need to implant the other ear, and we may also cut the electrode in the carotid canal if required. So that's something we always need to have. Okay, let's see how the surgery went off. This is the video of that surgery. We'll see a lot of fibrosis, as I mentioned. Let's say fibrosis which is present in the antrum. This is all entangled inside. Now we have to preserve the implant because that's not something which the patient's family can wear. We went right to the site of cochleostomy. You see that's anchored inside that. We tried to dissect it off. We know we cannot pull it off very hard because the carotid was involved here. And then we could dissect it off. The electrode was pretty kinked. We actually tried to straighten it the way we could. And then this is the neo-osteogenesis which has happened in the last 5 months. So it's operated in November and we operated in March. So that's the new osteogenesis which is probably present. We see the incus is absent probably because of previous surgery. That's the suprastructure which we see. That's the scala vestibuli we are trying to open up because the scala tympana was anyhow meddled with, we know it previously in the previous surgery. But we couldn't even get a lumen in the scala vestibuli. So we had an issue. So we decided to do a middle turn cochleostomy. Now intraoperatively, in fact I talked to Dr. Mohan Kameshwar regarding this patient also. We went in and that's where we drill a middle turn cochleostomy, right? That's a midpoint between the oval window and the processus cochleariformis, perpendicular to the promontory. That's where we have gone in. We threaded the electrode array through the posterior tympanotomy and then inserted it into the middle turn of the cochlea. Now, we would have been happy to get 12 electrodes in. That's what we expect in a middle turn. And when we look at, we got the NRT done intraoperatively. We had 16 electrodes functioning. So that was something we were pretty happy to have. We got this CT scan done post-operatively. See the basal turn not touched because that's where it was fibrosed, and the electrodes lying in the middle turn and then going into the apical turn only, right? The basal turn was not really which was now being touched. So now becomes the role of a good audiologist who would actually map the electrode array so that the frequencies are not an issue, and that's what had to be done for this patient. Okay. Now the another important thing which comes in is extrusion of cochlear implants. We all are bound to see them. One or the other time our implants will get infected, and that's what happens with these patients, right? It's so sad to see these photographs, and most of the times the only thing we're left with is explanting this kind of an implant. Now importantly, what are the factors which cause extrusion? It could be, most importantly, improper sterilization during the surgery. It could also be because of pressure of the magnet over the flap, if it's too thin or you're using a very thick flap. If the implant is too much near the incision, or a trauma, and rarely what has been described as silicone allergy. Now silicone allergy, let's go to the next slide, is something which has been a paper published on it. It actually mentions that a silicone allergy, they had 3 case reports on it, which actually talked about, and then they did even a skin sensitivity test and found that it was because of allergy to silicone which led to that. However, it's not something which I would believe in. It's kind of a reason which we are trying to give so that we justify our wrongdoings. So that's the real reason would probably be something different, and we have a paper from our country, from Dr. Neelam Vaid, which talks about a biofilm infection in cochlear implant, and that's what is the most common cause for an infected implant requiring explantation, and not silicone allergy. So options are explant and then do a cochlear implant in the opposite ear after 3 months when the infection in the whole body settles in. Importantly, does the Indian scenario allow us to do that, right? We have government funding, the governments would not give funding for the other ear. We have funding from NGOs and philanthropists which need to be taken care of. So we need to save this implant. Importantly, the question comes, can we? And I think here comes the statement by Mr. Barack Obama, the erstwhile President of America, and that's what it is. Yes, we believe we can save such implants. Now we need to plan our incision in that proper manner, right? So we need huge rotational flaps which are inferiorly based on the occipital artery. So that's the incision line which needs to be there. And then you go ahead and excise the infected area. You elevate the skin flap off, inferiorly base it. You elevate another flap superiorly of the periosteum. That's the site where you will be placing our implant now, much more inferiorly. Remove all these infected areas of tissue which are seen. Scrape off all the biofilms. Can you go to the next? So remove all these slimy biofilms, debride it off, take care of the tie down holes, and then we make a separate bed for the implant now, right? No shortcuts in that. Cover this area implant and then support the fan tail of the electrode with the conchal cartilage and then suture it up, right? That's what we have been doing with our implants now. This is a photograph of maybe I think 3 months post surgery, and for a Varia technique which has been done, then this incision needs to be modified because that's a different incision we are taking care of. So this is the way it actually lands up at. So we have done it in 7 of our cases which have been referred to us or done at our center, right? So only one of them Varia because primarily our area is a posterior tympanotomy area. Most of them have been nucleus implants, again because mostly it has been nucleus which has been done in our area. We could salvage the last 3 probably of our implants, right? And that's because important. After the first 3 implants, we have started doing this big rotation flaps, which would be very helpful to really take care of this. We have been 3 of these patients were referred to us from other centers, right? So we have a study from India, actually Dr. Shalab from Delhi, which he has used tea tree oil to take care of this biofilm, right? And that's something which has been interesting to see and to salvage it out. Okay, so that's what you can do with your extruded cochlear implants. Another thing which is a simple problem is a displaced magnet, right? The patient is not able to use an implant. That's because the magnet has got displaced. It's a very simple surgery, but you give a small incision over the upper aspect of the implant, expose the area of receivosimeter package, replace the magnet in by simply putting it in with the help of a forceps. Remembering it's a magnetic thing, so it would actually be very difficult sometimes to place it. It's just that you need to play with it a bit, and then you just deposit it in its pocket and it's done. Right, and this is one of the most interesting revision case. This patient was implanted about 2 years back, doing very well. Just the only complaint being pain and mild swelling posterior to the implant side, right? We got an X-ray done. So this is the receiver stimulator package still inside, right? That's still inside the body of that patient. So obviously, which we had to remove, and the patient is doing well. Okay, so can we have this video, right? It's football season. Take home message. Let's see with this what this football. It's a penalty kick being done. Can we play that? I hope that plays. So the things which we it was just playing. See. So what we need to say, realize now. You need to click on this again. Oops. Okay. Yeah. So this hit the bar, and therefore the goalkeeper celebrated it. It's important we do not celebrate with our patients too early. Do not lose hope early as this shooter was doing, and never leave the patient till the job is over, right? Because, and that's for the cochlear implant, a lifetime. These patients would keep coming back to us for their lifetime. So these are three things which we always need to remember, right? So this is where I think we will end. I'll end again with these people whom actually have made everything possible. They are the ones who have made me what I am. They've inspired me. They have been there a phone call away whenever I needed some things to be answered, and whenever I needed something stupid to be answered or need myself to be rejuvenated, I contacted the first 5 people in the row. So that's something which is the most top row, which are still the best for me. And this is the team led by our head of department, Man Prakash Sharma sir. So that's where we are actually working on different aspects of ENT. And thank you all for that. And it's been an exhaustive vision. Let me thank Dr. JANAKIRAM sir for inviting me over, and Alembic for giving me this opportunity to talk about a topic which is very dear to my heart.
So, thank you, Dr. Monish, but I think you're not yet done, because we have a few more comments, some questions from me, and also from observers. Just a comment before we start with the questions, that we are being watched by around 13,000 people around the world. Okay. Do you believe it?
That's amazing.
So that's really amazing that no conference can have a hall which can accommodate 13,000 people, at least in India.
Yeah.
Right?
Yeah.
So 13,000 people watching you and your lecture is something which Alembic and Royal Pearl thought about, and it was actually my brainchild. When I shared it with Alembic, they said, "Wow, it's a beautiful program. We'll do it." And the head, Mr. Rajit, immediately bounced on this program, and now we are on it now. This is the 3rd program, and next week, in fact, we are going to have Dr. Vikas Agarwal for the OSA. And before we actually talk about all those programs, I just want to tell you that tomorrow morning at 10 o'clock, we have a live surgery done by Dr. Monish Grover. You'll be seeing his live surgical techniques, and we are doing it in a 1.5-year-old child. Now, before the questions again, I want to add a few comments. In fact, India is such a big country with 1.2 billion population, and we should really thank 2 great people who actually initiated the implant program in India. And I really want to name them now, because this is the right time for all of us to name these 2 people. Absolutely. And one would be Professor, my teacher, Professor Milind B. Kirtane sir. Actually, I have greatest regards for him, and in fact, I saw him operate. It's like, you know, watching a Rolls Royce or a Mercedes going in a German road. And second, definitely would be Padma Shri Mohan Kameshwaran sir. Really a great pleasure to watch him. Last implant was done by him in our center, and it was a real pleasure. But of course, not to forget one of my great mentors, Professor Rajesh Vishwakarma sir. In fact, one of the beautiful cochlear implant surgeons I have ever seen. And of course, you have put the picture of so many others who are all there, who are leading our country with the cochlear implant program. And now the youngsters are really coming up, and a lot of new centers are coming up. Now, I have a few questions from my series, a very small series, but because, you know, we are primarily a skull-based center, I also have a lot of inquiries regarding implants. I just want to know a few queries to be sorted out. We've had wound infections for 2 patients, and in fact, we were in a dilemma. We gave antibiotics. It happened around 1 year after the surgery, the patient had a wound infection, that is a little, the implant side. And what would be your take on it? 1.5 years after surgery, what would be the reason for such patients?
Okay, so that's an important thing, because when it happens after some time, the parents really don't like it at all, because the child had started hearing and they had started having results, and now this thing happens. Now, why this can happen? Now, if it's 1 year down the line and there was no problem before that, it's probably some trauma which inadvertently happened while the child was playing, which has led to this. If it would have been, the history would have been that there were some episodes of infection, some episodes of repeated swellings even without pain, then we would have to look in that episode. Yeah, so it's probably some trauma which has given rise to this infection. Now, if it's post-trauma, then the chances of this implant being preserved are higher rather than simple infection. Now that depends on the type of infection which you are having. By that I mean, if it's just simple collection or erythema of the skin, then antibiotics and sometimes steroids are very good. There are studies which have been done which even sometimes label rifampicin as a very good drug to take care of it. That's something which Dr. Neelam Vaid actually advises, and that's something which I learned from her. So that's something which can be done. If it's, however,
can you repeat it? Actually, it's a very good because
okay,
we
so,
use that.
Yeah. So the point here is, if you are looking for an infected implant, one of the antibiotics which has been advised is rifampicin, right? That's considered to have a good role.
Rifampicin.
Yes, rifampicin. Yeah, so that's something which Dr. Neelam Vaid actually really talks about it a lot. There have been papers on it which tell us that the results with rifampicin are better than others. So that's something which has been now put into practice at many centers. Also, the fact that if the skin has got breached because of trauma, then you need to sooner than later really plan out a big rotation flap, which we discussed, and try to preserve the implant. Now, the chances of this preservation may be hardly 50%, because once it gets a skin breach, once it starts getting infected, the chances of really being able to preserve it go down. But still, that's worth a try, because it's something which is important for that particular patient, and that's what we are looking forward. So if it's skin breach, use a rotational flap. Post trauma, they do much better than an infection which has been settled down primarily during surgery. So that's what usually happens.
Okay, that's a good point. And I want to ask you regarding the vaccines which you advise, because some are against or some for. What is your protocol in your center regarding the vaccination, and how far before would you vaccinate a patient?
Yeah, so the protocol which we follow is vaccination is against Haemophilus influenza B and pneumococcal. Now, we want these to be done at least 20 days prior to the surgery. So these two, Haemophilus influenza B and pneumococcal. If the child has already been vaccinated, for example, tomorrow we are operating a 1.5 year old child and 1.5 year old child, and she has already been on the vaccination schedule, taking Haemophilus influenza and pneumococcal in that schedule, then you need not vaccinate again. If it's really going on right now, we are pretty happy to be on that aspect.
So one other question, which is actually $1 billion question. Of course, I don't want to raise a big controversy on this, but definitely I want to have your views on which technique would you like to follow. That is the varia or the posterior temporal.
Yeah, so yes, both the techniques actually work. It's basically the surgeon behind the technique which is more important. Now, for me, posterior tympanotomy is all the way, right? It's only posterior tympanotomy is varia for me, and I presume it's actually the fact. In fact, there's a paper by Tarabichi, the endoscopic ear surgeon, right? It's 2016 laryngoscope, where he mentions that a transcanal access to the cochlea, which is there in varia technique, gives rise to more of in-ear trauma rather than the posterior tympanotomy technique. So that's something which is important to realize. Also, the problem which I think varia really gives is that the electrodes which you are using, you cannot really use an insertion tool to insert an electrode which comes with many electrodes, many implants. Also the fact that if you want to really use an electrode with a stellate, which you want to really not go in completely when you're putting an electrode, that becomes difficult with the varia technique. Round window insertion again is comparatively much more difficult in fact, is something which is only very, very experienced surgeons can do, and especially if you're dealing with a posteriorly rotated cochlea, it would be very difficult, almost impossible to do a round window insertion through the Varia technique. So for me, it's all the way posterior tympanotomy gives me the versatility to do all the things which I want to with an implant and electrode. It's only if I'm not able to do it with a very narrow facial recess or a very high lying forward lying sigmoid sinus is there, will I go resort to elevated tympanomeatal flap and then under vision do a posterior tympanotomy and then go about it. So for me, it's only posterior tympanotomy.
So you would prefer a posterior
Any day.
tympanotomy approach?
Any day.
Okay. So suppose the patient actually has a problem with the Montini or dysplasias. So how would you counsel this patient? Because counseling of a patient for cochlear implant, if they are going to pay out of their pocket, not in a government setup, if they're going to pay, is going to be an issue every time when we do an implant, right? So what would you how do you counsel these patients?
Okay, so the important thing is, even if it's government funding, we have our patients whom we have operated on malformations. We need to tell them pre-operatively that your child's results may be compromised, right? Whatever said and done, malformations have compromises. Now, Mondini's per se, when we deal with an IP2 anomaly, the results are not as bad, but still it may be lesser than a normal cochlea. The moment we go beyond Mondini's to more severe malformations, the results are definitely worse, and you need to really counsel them well that do not compare your child to the child who has undergone a cochlear implantation with normal cochlea. This child may be only able to hear certain sounds and not develop a good speech, may not have a very good speech discrimination, will always have a higher chance of a CSF leak happening, meningitis happening. The precautions will be taken. Also, higher chance of a facial paresis if the facial may be anomalous. So these all things are things which you need to take consent about before starting your surgery, especially the prognosis, because as Dr. JANAKIRAM just mentioned, the results would be compromised the moment we land up with any kind of a severe malformations beyond IP2. So that's where we need to counsel them well that do not compare your children to other children with cochlear implants.
Yeah, we have some more additional queries from our center because we are a large volume skull-based center. So in fact, we have operated on NF2 cases. We regularly operate on acoustic neuromas. So in fact, we have one case for brainstem implant as well in the coming month. Now, what is your experience or what is your comments about brainstem implants and their results?
Okay, so no personal experience, but I've been in touch with those who are involved in auditory brainstem implants. First thing we need to realize is prelingual patients, the results are very compromised. If at all you have a chance of putting in an electrode of a cochlear implant in, do that, right? Even if you get 10 electrodes of a cochlear implant in, that's better than going ahead with an ABI. Whether it's an ossified cochlea or a malformed cochlea, plan for a cochlear implant first. Even if this is an absent cochlear nerve or an aplastic cochlear nerve, the protocols which go are that try with a cochlear implant first. If it doesn't really help you, only then do you plan for an ABI, right? Because sometimes, and that's where an audiologist comes in, your hearing signals may be traveling through the vestibular nerve, and the patient may be hearing through that, even though anatomically MRI is not able to detect a cochlear nerve. So cochlear implant, even if very less functioning, is better than an ABI. An ABI would be better for an NF2 or a post meningitis patient, which you just talked about, NF2, it would be much better for these patients. It would not be so good for prelingual patients. So if no option is there, we go ahead with an ABI, but still NF2 will do much better. And if you have actually preserved the nerve very well, then you can try a cochlear implant even in NF2 patients. So an acoustic neuron operated with a preserved acoustic nerve, people are actually going for a cochlear implant in these patients as well. So if at all this is not possible, only then an ABI. And then the important thing is the switch on has to be done in an ICU setting, because those electrodes may actually stimulate the nearby nucleus of the 10th nerve, the vagus and other nerves, which may actually cause issues during switch on itself. Yeah.
Yeah, I think that's a perfect answer to the question. Actually, I want to ask you some scenarios in India, particularly because there are so many viewers from India watching this program. In fact, in our state, that is the state of Tamil Nadu, if you take the government program has been very effective, and people like Padma Shri Mohan Commissioner sir has actually brought in so many changes into this implant scheme, and also got in ABT centers all over the state for the habilitation program. So what is the scenario in India and other states where you implant a child where you don't have adequate resources or centers for habilitation? What's your comment, and what is the status how do you go about that?
I think that's something which we all need to really think over. That's something which is very important thing which sir has brought out. What's happening now in India is with the more of government sponsored program coming in, and everybody kind of wanting to be a CA surgeon rather than being a good otologist is something which is actually hampering the things. We need to realize it's not just one surgery involved here. It's a huge team involved. You need to be really sincere towards this, because it's kind of a big balloon otherwise which is going to burst in many places when these kids would not give us results, when these kids would land up as non-users, right? There are a certain percentage of these kids who land up as non-users everywhere. They stop using implants. So we need to realize that we need to start surgeries only at those centers where you have good AVTs attached, where good therapies can be done, good speech therapists attached. Especially if possible, the speech therapist the speech therapy center should be as near to the residence of the patient involved. The surgical center may be far off. They may get operated in Jaipur, but the speech therapy center should be near their house, because that's why they need to come twice a week and then once a week for their child's therapy, for the mapping of the implant. If that's not there, the whole program goes waste. So please do not just fall in line that we have to do a cochlear implant. Don't just think about it. You need to first make all these things come together and then plan an implant. Otherwise, the whole thing will go up zero.
Again, another question which comes into my mind is that we have a lot of medical tourism. In fact, if you look at our center, we have almost now around 20 patients in our ward from various countries. Now, if this is going to be the scenario for cochlear implants, now the problem is when you habilitate a patient, they want that native language, right?
Yeah.
So, what's your comment on that habilitation therapy with respect to language? Whether you can go unilingual or bilingual, what kind of habilitation would you advise?
That's something very important. Now, that's important because, in fact, recently I was operating in a workshop where the patient was from Turkmenistan, and we were just discussing that aspect of it as to how will this patient undergo rehabilitation. How will you undergo rehabilitation when you do not have a rehabilitationist who can rehabilitate in the local language as well? So here comes the importance that one, if you are operating such patient, you need to be in touch with the speech therapy center back there at their place. You need to counsel that speech therapist. Now we have things like tele-speech therapy which is being done. Even you can do mapping sitting here and being taken care of at Turkmenistan or any other place in the world. But that is something which has come in our help. We need to be very sure that at least for the initial 3 to 6 months, the patient will come to our own centers where we have more experienced speech therapists. Because back home when they do not have experienced speech therapists, the results are bound to go haywire. So just leaving them operating here and let them go is not something which would really give us any results. We need to be sure that they stay back with us at least for 3 to 6 months, if not more. And by that time, we can really have a good reputation with the speech therapist back at their home. So that's a difference between the other skull-based surgeries which you do versus a cochlear implant, because it's more after the surgery. 90% of things are done post-surgery. The results which would come in are more post-surgery rather than what happens during surgery only.
Yeah, well taken. And I have a last question to wrap up the session. See, many people come and ask, the first question they ask is that, Doc, you're talking about a cochlear implant. Now, will I have something outside? So, this is something which I'm sure you definitely get the question from all your patients. Now, what do you see would be the future of cochlear implants? Where are we heading?
Yeah, so that's something which almost every patient asks, and Indian setup, none of them really want anything outside their body. It's all which they want is an internal device. So when I'm trying to answer what the future has in, let me try to say what has already been done. Australia, they have already implanted on I think 7 patients with a completely with a device which we call as TICI, totally implantable cochlear implant. So that's completely inside the body of the patient, right? So that's, they have already worked on that. So in future there are some minor issues which need to be sorted out. One of them is the battery related issue. The other is the sound which comes in on your head. For example, even if water falls on your head, that would be really very painful to the patient. So I had discussed this same thing with a few people, one of them being Dr. Mohan Kameshwaran, and he is actually involved in a few projects in which this kind of devices are being developed. And one of the issues which he said was the battery. And he said that he made a very interesting statement, and the statement was that the cochlea itself can generate enough electricity so that we can power a whole city for 24 hours, right? So one cochlea generates that much of electricity. So if there are some projects which are trying to channelize this energy of cochlea into charging the cochlear implant itself. So that's a very, very fancy and interesting thought, which if it really comes into practice would be a great thing. The other person whom I discussed this was one of the inventors of cochlear implant, Professor Graham Clark, and I met him in Munich, and I asked him as when do we think the stem cells and gene therapy would come in and replace the cochlear implants, and his answer to me was, don't worry, this will never happen in your lifetime at least. So that's what we are looking at.
Yeah, so I think we have one more question. I'm sorry, it just struck me now. So what is the present state, just for the youngsters who are watching it, what's the present state of this indigenous implant? A lot of talk is going around in India where they're going to manufacture at a low cost. What's your comment on this?
Yeah, so I think it started way back when Dr. APJ Abdul Kalam was our president. I remember I was doing my post-graduation at AIIMS in those days, and they were partnering with DRDO, which was involved a lot in developing this implant. Now ISRO is actually involved in that, and so it's kind of working. Our scientists are working with few people, and we have actually developed that implant. Animal trials are already being done. It's been tried in cats. Now it's being manufactured mainly in Indore, and there are few centers which have been identified across the country where clinical trials would be done. Right. So only after that will we see that in real picture as to how much effective that is for our patients.
So, Dr. Manish Drover, it was a fantastic, very elaborative and exhaustive talk on cochlear implants. I think the postgraduates and young consultants, of course, and some cochlear implant surgeons would have benefited from this. I'm sure that you all had a very, very good, pleasurable evening with us, connect with the legends. Thank you very much for being with us, and I'm sure you will tune in tomorrow at 10 a.m. Indian Standard Time, and that's going to be a live telecast of an implant which is going to be done by none other than Dr. Manish Drover in Royal Pearl Hospital, Trichy, Tamil Nadu, India. Thank you very much. Good night to all of you, and good night from
Thank you, sir. Thank you very much for having me here. It's been a real honor, and let me thank Alembic also for hosting such things which are really important for all of us. It's such a big outreach which is now possible because of such kind of webcast. We can actually be in touch with so many younger lot, so many people across the country and the world, in fact. So thanks to your initiative and Alembic that we are doing this today.
Thank you.
Thank you.